Pete's just getting it going now. Okay, we're on.
Okay, thank you very much. I think we better get started. I'm sorry we're running a little late. We have a couple of people still to arrive. In fact, Olivia Butterworth from NHS England is currently in a taxi on her way from Cambridge Station, having come down from Leeds this morning. But I think if we get started, we can quickly do some introductions, and I can start the session off. So thank you very much for giving up the time to come. The first thing to say is we do appreciate how much of a commitment of time these events are. And the work that we're doing, I think, is really important in terms of creating different ways for people to talk to the NHS and to hold NHS England to account. So it's a really important thing to do, but it's also quite a abstract thing. So I do know it's a commitment of time, and thank you very much in advance. And in return for you giving up your time, we're going to be working you really hard, but with a guarantee that we will finish by 4 o'clock. If someone's in the middle of a sentence at 3:59 and 59 seconds, I'll be cutting them off ruthlessly. Everyone's going home at 4. Possibly before if we get through the things we need to do, but certainly by 4. So I'm Anthony Zachaszewski, and I run a non-profit organisation called the Democratic Society. And with 3 other organisations, we're helping NHS England create this thing called NHS Citizen. Now, I want to talk a little bit about what that is, but before I do, we've had a couple of people ask whether we can do introductions around the room so everyone else knows who's here. If you feel like you don't want to be, known, you don't want to kind of say, oh, I'm so-and-so, that's fine. But I'm going to pass the mic round in a minute. If you could just quickly say who you are and why you're here, not in a philosophical way, but just, I'm here from Surrey County Council or whatever, then that will be brilliant, and then we'll all know who each other is. Then I'm going to talk a bit about what NHS Citizen is, why we're here, what it's for, what we're trying to do with it, and then we can get into the bit where you do all the work. So I'll quickly grab the mic. Would you mind? Thanks. Thank you.
Okay, good morning. Is that working? Good morning, everyone. My name is David Brewer. I'm the Head of Engagement at the East and North Herts NHS Trust, which is based at the Lister Hospital. And I'm here because I'm very lucky. I've got a great job. My organisation empowers me to really spend all my time engaging citizens, communities, patients, and really trying to put the hospital back at the heart of the local community. So NHS Citizen is something I'm extremely interested in and very happy to spend time to help and make it work. Thank you.
Okay, thanks. If you just pass it round.
I'm Anne Gower. I'm a councillor from Suffolk. I'm a cabinet member at St Edmundsbury Borough Council in charge of housing and social care, and I'm assistant cabinet member at Suffolk County Council looking after health and adult care.
Morning everyone, I'm Vicky Raphael. I'm a member of Inclusion East, which is a group of families and people with very complex learning disabilities right through the eastern region, so we rely on health and social care very heavily, and I'm really sort of well connected across the region.
Hello, my name is Fiona Carey. I've been a cancer patient since 2001, and I'm involved in the East of England Citizens Senate. I said that right today. I called it something else the other day by mistake. The East of England Citizens Senate, and a patient user group at Addenbrooke's, and I've been involved with these guys for about a year, and do some other national things with the NHS as well.
Hello, my name's Sue Larson. I work for Cambridgeshire and Peterborough Clinical Commissioning Group, and I work in public engagement, so I'm really keen to get even more information of how we might engage people in clinical decisions too.
Okay, so you pass it to the table behind.
Hello, I'm Bobby Heller, and I'm a member of the East of England Senate. I hope I've got it right. And I also am part of a patients group called the Hunt's Patients Congress, and I do voluntary work at the hospital, which Hinchinbrook Hospital, which includes working out how you get there by bus. It's rather complicated, but I do write reports for them at regular intervals, for which they seem very appreciative. And although it may not actually be part of this. I teach the elderly retired just down the road at the University of the Third Age, and I've acquired an awful lot of information about people over the age of 60 and just how with it they are. And they're not all, though obviously there is a problem with the elderly, there are an awful lot of the elderly who keep the system going.
So true.
Hi, I'm Tara Redman. I'm a young health ambassador with the East of England Strategic Clinical Network, and I'm also involved with the East of England Citizen Senate.
Hi, I'm Alex Burrows. I'm a young health ambassador for the Strategic Clinical Networks.
Lorraine Rollo, I'm a Communications and Engagement for Great Yarmouth and Waveney CCG, and here to find out more about NHS Citizen.
Tony Rollo, as it happens, yes, we are related. Though we met in the corridor. I'm a member of the Citizen Senate. I'm chair of Health Watch Suffolk, and I'm also chair of the East of England SCN's Cancer Partnership Group.
Okay,
fantastic. Which I think is probably enough.
You pass it on to that table there.
Hi, I'm Stella Colwell, and I'm the chairman of Ipswich Hospital's overarching user group. I was part of the Clwyd Heart review team looking into how complaints are handled in acute hospitals, in NHS England hospitals. I'm particularly interested to know more about how we can work as an equal partnership with the professionals in hospitals, and particularly outreach into the community, so working with the CCG and developing relationships in that way.
Thank you. Good morning. My name is John McKinnon. I'm Head of Innovations and Customer Insight for Essex County Council. I'm also coming from my day job, which is the Director of Adult Social Care for North Essex. So I'm here today to try and understand how NHS Citizen works, how it looks for the future regarding the Better Care Fund, and how health and social care can find that common ground. So one person, one voice, one issue, one action. Thank you.
I'm Paul Folger. I'm a patient from Danby in Essex. I'm a member of the Citizen Senate, and in 2001 I set up the Cancer Services User Group in Chelmsford. I'm still involved with it today. I'm chair of the Mid-Essex Donor Support Group, and my real reason for being here is making sure the patient's voice is heard.
Thank you. I should just say the reason we shimmied across the room, it was not sort of a coordinated dance move. It was because we were in the way of the cameras. Just to say that we're being webcast, and so that's why we've got mics and things, even though we're quite a small room.
Good morning. My name is Trevor Fernandez. I'm an ongoing cardiac patient. I co-chair the East of England Citizen Senate with Fiona Carey over there. I want to know more about NHS Citizen, but also to promote the work we do and what we do is for the East of England Senate.
Helen Vardulaki, I'm an ordinary citizen. What brought me here are the changes in the National Health Service and to find out if there is hope.
Good morning, everyone. I'm Debbie Roberts from Hertfordshire County Council. I work for Youth Connections. I have 3 hats. I support young people, get involved with scrutiny groups, and I'm a project officer, and I'm the lead delivering on the RSPH Youth Champion course.
Hi, my name's Anne Robinson. I am a patient from the CPFT Mental Health. I am at the moment in protest with LifeWorks, and I'm looking to get involved to just be a voice to mental health to make sure that they do have a voice.
My name's Jean Simpson. I've retired from the NHS. I belong to Keep Our NHS Public and locally Stop the Sell-Off group. I'm very interested in seeing that clinical commissioning groups and all other bodies that you all seem to represent actually do hear the patient voice and actually start to communicate with us and listen to us.
I'm Mark Anderton. I'm a director of Health Watch Norfolk, so I'm enjoying that while Health Watch lasts, so make the most of it. And just to be funny, so I laugh. And also, I'm a member of the Citizen Senate and some of the subgroups. I'm also a governor of SLAM, which is South London and Maudsley Trust, so we're doing lots of important work there. I'm also a trainer for my Mental Health Trust, and I'm actually here today to, above all, make a difference and see what this wonderful potential this new initiative has.
Okay, thank you. Do you want to, yes, pop back on?
No, my name's Chris Van Holby, and I'm a member of the East of England Citizen Senate, and I'm a retired local government officer. And my sort of claim to fame, 20 years ago, I worked on a contract for a couple of years with the NHS in Yorkshire and launched the John Major Patients Charter when we introduced an interesting concept of GP commissioning, which sort of petered out.
Hello, my name is Leslie Billy. I work for a service user-led organisation based in Hertfordshire, supporting individuals with mental health or substance misuse to have a voice in terms of commissioning and delivery of services. And this is my first real interaction with the NHS citizenship, so I'm really interested to see how this pans out for today and take back the information back to service users. Thank you.
Hello, my name's Mary Simpson. I work for NHS England in the Midlands and East region, and I work on patient and public voice. So it's really good to have so many people here today and to hear and to take part in this initiative. Thank you.
Hi, my name's Sandy Smith. I'm Chief Exec of Healthwatch Cambridgeshire. I'm here today to see how we can all contribute and work together, basically, so that people's voices are heard loud and clear and that we get the best for people.
Hello, I'm Peter Durrant. I used to be a social worker and retired 20 years ago, but I never liked social work. So I used to call myself a community worker. And it's good to see, and I had a nice conversation this morning with my colleague from Essex about the Barclay report and the Seabourn report. And I do think the Barclay report, 27 years on, is geared to us thinking about social care, the NHS, in a more collective and cooperative way. My last point is I don't like also the concept of the NHS. I think it's too narrowly defined to hospitals and primary care services. And if we thought about our employment, vocational ability, housing, these are all factors of health, of course, and the narrowness of the description sometimes fills me with despair.
Okay. Yeah.
Hello, my name's Geeta Pankania. I'm ex-NHS. My background is public health, equality and diversity, and I'm a trained trainer, and I'm here to ensure that the minority voice is heard, and I have a lot of experience in working with black and ethnic minority communities and the wider migrant communities as well, so that's why I'm here.
Good morning, my name is Sonia Cullington from Wow Fitness. I set up wellness groups in the community, and I also work for public health in Peterborough. I specialise in community work with GP referral, mental health and plus size, and my oldest client is 100 and is rocking.
Hi, I'm Sally Pepper. I'm a patient. I'm a type 1 diabetic. I'm a patient at Addenbrooke's. I've had some battles in sorting out my care, and it's now going really well, but I'm interested in how that experience can be improved for others.
Last but hopefully not least, I don't know. Hello, my name's Justine Thompson. I'm a cancer patient as well, and that's how it all started for me. But now I'm behind trying to get the Citizen Senate, East of England Citizen Senate, up and running and to be meaningful and to achieve things for people and to make sure that we get heard.
Great, thanks, Justine. Okay, just a few more introductions to make. Firstly, myself, I'm Clive Mitchell from an organisation called Involve. We're one of the organisations that Anthony referred to earlier, working with NHS England to get NHS Citizen going. And just to say, Justine is going to be doing a slot later on the work of the... and a number of others from the East of England Senate, so not just Justine. So after lunch that you'll be hearing not just from us and not just from everyone else. Stefan and Pete from Public Eye are over there looking after the webcast and the technical stuff. And if I can hand over to Olivia to perhaps and Nagina to introduce yourselves. Thanks.
Thanks, Clive. Good morning. It's really good to see so many faces, and I sat at the back listening to the experience that's in this room. It's astonishing. Thank you. Thanks for giving us your time. My name's Olivia Butterworth. I'm Head of Public Voice at NHS England. I suppose I'm the responsible official sort of behind trying to make sure we do this in a sensible way. So I'm not really going to say very much today, I don't think. But I'm really interested in how we design this together. So this doesn't exist yet. So a few people in their introduction said, I'm here because I want to know how we can work with it. There is no it yet. And that's, I think, possibly quite unique. And I think it's similar with the work Justine's been doing and many of you with the Senate, about how do we design something together that becomes useful, that is structured and formed in a way that has voice and impact, rather than a model that's then imposed on people. So it doesn't exist yet. So how can we make sure that it does have the voice of users at the absolute centre, that it really does reflect the work that you're doing, and it's a sum of the parts rather than being an addition. And Nagina, do you want to say who you are?
Hello, I'm Nagina. Hopefully you've met me this morning. I will be your tea lady and support today. I work with Olivia and I'm supporting the development of NHS Citizen.
And possibly worth just saying, both Nagina and I sort of worked together many years ago in Keighley in West Yorkshire, both with a voluntary sector background. So my background is as a community worker. I was a community development worker, I was a youth worker, and I've been banging on the door of the NHS to join up around health and housing and social care and all of those things. And it kind of feels at the moment we might be starting to do some of that a little bit more sensibly, and perhaps some of this work and the stuff that you're involved in might again be helping us to break some new ground and help people to think differently. And I think that's part of what we're doing with this, is getting people to think differently and think about their culture and behaviours and attitudes and how they provide the boundaries around which we work, and perhaps we can rethink some of those.
Okay, thank you very much. Well, the thing that I took, like Olivia, from that going around the room was how many different sorts of voices we have here, and how much expertise as well, both as people and as patients, but also people who understand how the system works. So I hope we can pull all of that together into a really good conversation over the course of the day. We've got some questions that we want people to think about. What is NHS Citizen is the one that we'll be answering, and you'll be answering the others. So I'm going to talk in a minute about what NHS Citizen is and how it's meant to work. The questions I want to talk about here, because we have so many different bits of the system in the room, local government as well as CCGs, patients as well as clinicians and citizen senate types, I want to think about how do you actually get issues and conversations into the NHS Citizen environment? How do you make sure that all the voices are really heard? But most importantly, how do issues come out? How do you make sure that when you raise something, you know, if other people want that issue raised, how do you get answers? So we've said all the way through this process, there's no point in creating a brilliant mechanism for collecting stuff if there's no brilliant mechanism for putting stuff back out and answering people's questions and making sure that people know they've been heard. So that's one of the questions we want to ask you. How would you make that happen? How would you want to know that something had been done? How would we manage online and offline? So NHS Citizen, as you'll see when I talk through where we're at with it at the moment, is something that is enabled by digital technology. You know, the fact that we can have a joined-up conversation between Plymouth and Cambridge on issues that, you know, that matter to them is enabled in large part by digital technology. We're webcasting this because we want to have a record of all of the conversations that we have in this room, and we'll be writing a blog post about it. We'll be taking all of the notes that you make on tables and writing them up, so there's a digital archive of what's happened. But digital doesn't work for everyone, and it doesn't work for every circumstance either. You know, I don't want to have a digital meeting about what's happening on my street. I want to go to my community hall and have my meeting there. So how do you record and how do you bring those offline conversations in without having, you know, Pete and Stefan rushing up and down the country webcasting every kind of tiny gathering? So there's a question for us there about how we manage online and offline, because it's very easy to focus on the simple and the cool of digital without trying to think about how you manage that for people or situations where it doesn't work. This afternoon, after lunch, we'll be hearing from the Citizen Senate, and Justine and others from the Citizen Senate will talk a bit about what it is, so if you don't know what it is, you'll find out, but also whether it's a way of modelling how NHS Citizen could work at a regional or a local level. Because I think the most important thing to say about NHS Citizen, which is also the hardest thing to understand, is it isn't an organisation. There will never be a chief executive of NHS Citizen. There will never be an office with a brass plaque on the door that says NHS Citizen. It's a way of working and connecting all of the other things that are going on. And that's what I think is quite hard to understand. So it's hard to understand in one sense because we haven't designed what it is yet, and that's what we're doing here. But it's also hard to understand that it isn't an organisation with its own territory. It's trying to be the thing that joins up all of the existing patient and participation work. I can't remember where I read the statistics, so it may be wrong, but I think there are 3 million people who in some way have said they want to be involved in the NHS, either as part of an expert patient group or a member of a foundation trust. But all of those 3 million are in little pools, little puddles of engagement all over the place. And NHS Citizen is in part designed to connect up that public conversation about the NHS, to make the voices louder and to make sure that the NHS England board and other bits of the system can't ignore it. So that's what we're trying to do, and that's what we're going to be talking about over the course of the rest of the day. Are there any questions about practicalities? And otherwise I'll just kind of do a little bit more talking about what NHS Citizen's meant to be.
Yeah, you're standing right through the camera.
But it's okay, because the camera's on me. So yes, there's cameras all around. I should say, if you feel uncomfortable about being on camera, that's absolutely fine. You know, Pete and Stefan can make sure that you're not covered by a camera angle. You might have to move seats, but we can do that. So if you feel... We could do that too. We could do have goal line technology as well. You know, it'd be brilliant. But anyway, so if you do feel like you don't want to be on camera, then just tell Pete, and we've got a sticker that you can wear to show that you don't want to be. But anyway, just to yes, Fiona. Oh,
no, hang on.
Oh, sorry, Mike. Yeah, sorry. The other thing is, posterity will not record your statement unless you put it on a mic, because it has to go onto the webcast.
Well, Trevor says he's not meant to be here. I want to know what he's told his wife he's really at.
Yes. Right. Okay, so Clive, you want to say something as well?
Just housekeeping before we kick off. So just to say that we're not expecting any fire alarms today. So if the fire alarm does go off, then it's for real and we need to evacuate. There are 2 ways out. One way is the way you came in, so out these doors and turn left and down the stairs and out the front entrance. An alternative route out is out these doors, and there's another fire exit marked in that corner. You go down some stairs, follow the signs and out onto the road in that direction. For folk who are using wheelchairs, that little lobby in the entrance there is the safe area. So those doors will be closed, and that's the safe area, just literally outside these doors there. Loos are on the ground floor, so if you go down the stairs, and if you turn left when you get to the bottom of the stairs for the ladies' loo, and you turn right for the gents' loo. And I think those are the essential housekeeping.
Okay. So let me talk a little bit more about NHS Citizen, just to kind of give you a bit of a frame about what we're trying to do. So Olivia said it doesn't exist yet, and that's absolutely right. But what does exist is about 9 months' work doing these sorts of events around the country and doing more detailed 2-day design events to try to work out what it might look like. So we started with a few ideas which have changed a lot. So what you're seeing here is version 7 of NHS Citizen. So we started with something that looked very different. And part of our principle of working openly is that you can see all of the things that we did. And you can see version 1, version 2, and version 6, and version 5.5. And also all of the webcasts of the events where we talked about it, and the records of them on our website, which is nhscitizen.org.uk. So you can see how things have developed. And I can talk a little bit, maybe, if people want to, about what has changed and where people did say, oh, that's not quite right, can you fix it? But what we're trying to create is a thing that is designed in the open and that works in the open. So it's meant to be a completely public space. There aren't sort of bits where, only special people have access or only NHS staff have access. It's a completely open system to try and connect and deliver public voice in a very different way. And at the last design workshop that we did in Leeds, we had a graphic facilitator who did this fantastic drawing. Now, I'll talk through all the little bits of it, so you don't need to understand it completely, but you'll also find a copy of it on your table. The thing that I like about this particularly is that it gives a sense of the idea that things move in NHS Citizen. It isn't just like a web forum where you just say your piece, and you said your piece, and that's fine, and maybe someone replies, and maybe they don't. It's about joining up the conversation, but also making that conversation useful and productive. So just to sort of talk through the diagram, there are 3 connected spaces in NHS Citizen. There are 3 things we're trying to do. The first is we're trying to join up the conversation, and that happens in this place called Discover. The second thing is we want to make it easier for people and organisations to raise an issue they want to have a conversation about. We want people, individual citizens, lobby groups, patients groups, even NHS organisations to say, we need to talk about this. Who else wants to talk about this with us? And that's what Gather is. And Gather has a process to try and take those conversations and turn them into recommendations or thoughts that then get fed straight into the right bit of the NHS. And the third part, over in the right-hand side, is the assembly meeting. Because NHS Citizen comes from a desire to make the board of NHS England more publicly accountable for what's happening in the system as a whole. And so, as well as hearing and reading what's going on, there's also a 6-monthly meeting where the board and people who've been participating in NHS Citizen meet together to talk about some of the big nationally significant issues that have come up. Now, not every issue that goes into NHS Citizen will be nationally significant. So we have to understand how local issues can be taken into the system and put out at the right level. Because if, I live in Sussex. If I have an issue with a particular health thing in Sussex, that might just be a reflection of decisions that have been made by the CCG. It might be nothing to do with the national level. So it would be a bit of a waste of time. Everyone not from Sussex will not be interested in it going to the Assembly meeting. So we have to make sure that things that come into NHS Citizen that are local go out in a local way and are answered in a local way. So that's what we're trying to do with the system as a whole. Let me talk a bit more about the individual bits. The Assembly meeting is not the World Cup finals. Right? So it's very easy to think, okay, so there's these conversations and then there are ideas and then the ideas go to the Assembly meeting. The Assembly meeting's like the World Cup finals. And, and you've got the qualifying rounds and you've got the football system as a whole. It really isn't. It's designed to be a centrepiece so that people know that NHS Citizen exists and there's an opportunity for people to meet and talk about it in a physical environment. But it's really not intended to be the ultimate goal of everything that happens with NHS Citizen. We'll have a member of the NHS board joining us later. And I think he himself would say, and maybe he will say at 2 o'clock, maybe I'm just stealing his thunder, the important thing about NHS Citizen is that you're hearing people's real voices rather than hearing prepared lines or argumentation that's been worked up through processes of lobbying or whatever it is. So when we did a test run of the Assembly meeting at the NHS Expo in Manchester, the thing that the board who were there really valued was actually listening to what people really thought and were expressing in their human terms rather than in policy terms. It's far more interesting for the board to hear, this is the problem, this is the way that the NHS isn't working right for me, than I think the NHS needs to change its policy on this by adopting this regulation or this directive. That sort of policy conversation happens all the time. But what doesn't really happen is getting the human voices into the system, and that's what NHS Citizen is designed to do. So the Assembly meeting's twice a year. We've got lots of questions about how it's going to work still. We're not quite sure how you're going to select the people who go. Would you select them randomly? Would you select them by picking up the people who'd been most active in the conversations? Would you find the issues first and then the people, or the people first and then the issues? So all of these things are still up for grabs. But one thing that we're getting certain about, none of this is fixed yet, but one of the things that's getting a bit more certain is there's a meeting of about 250 people with the board every 6 months. There's also, it says on here, citizens' panels. There's also the option of creating things like citizens' juries. I don't know if you've ever done anything like that. Basically, it's 12 people or more, 20, 30 people in a room for a weekend with the evidence and with experts and with good facilitation to try and come up with a solution to a difficult problem. So we've got the option to do that as well. Going completely to the other end of the scale, discovery is where we're trying to join those bits of conversation up. Now, when I say listening to the public conversation, there's two ways of listening to public conversation. You can say, let's have a public conversation and listen to it, or you can crawl around under tables in pubs listening to the public conversation. We're not trying to crawl around under tables in pubs, so this is not surveillance. This isn't going out and looking and seeing what everyone's saying. This is about finding people who are interested in bringing their conversations into the NHS Citizen world and making them part of that. So there's no compulsion here. If you don't want to be part of NHS Citizen, if you think that your ideas are not what you want to put in, that's fine. But if you do, you can. And we can pick up offline events, patient group meetings, conversations, events like organisations like the Citizen Senate, Health Watch, Patient Opinion, all of those sorts of bits of information can all go into the discovery layer. And the point of Discover is that if you're having a conversation here about what someone was saying earlier about the provision of mental health services in Cambridge, and someone else is having a very similar conversation in Portsmouth or a very similar conversation in Kent, then you can find other people who are talking about the same ideas. But also you can find out if you're interested in a particular issue, if you think that that diabetes is a particularly important issue, you can find the other people who are having that conversation. So not only for individuals, but also for organisations that are campaigning, this is a way of maximising the vision that you have of what else is going on. So it's important for that, but it's also important for the NHS system as a whole, because it's a way of connecting all of the very bitty, difficult-to-find conversations that they see going on all over the place. So it's meant to be something that has benefit for both sides, which is one of the principles for NHS Citizen. So the question is, you've got this huge conversation going on out there. I mean, 3 million people all talking about the NHS. You've got 250 people once every 6 months. How do you get from one to the other? And how do you get issues out of that kind of big soup of public conversation? Well, Gather is how we're trying to do it. And the way that Gather works as we currently envisage it, and I say, still a draft, still not fixed yet, is it's the place where you say, right, I want to have this conversation about this. So if you think there's an issue in, because the word's in my head, an issue about diabetes care in Cambridgeshire, you can say, I want to talk about diabetes care in Cambridgeshire. Who else wants to talk about that with me? I think this is a conversation the NHS ought to be having. Who else thinks this is a conversation the NHS ought to be having? And there is then a set of support for you to have that conversation in the way that you want to have it. So if you feel like you want to have a public meeting about it, then there are tools to enable you to have a public meeting, and you can say, we're having a public meeting in the Friends Meeting House on Jesus Lane in Cambridge on this day. If you want to have the conversation online, there are tools to do that too. And you can say, well, I like this platform or that platform. I want to talk about it in a Twitter hashtag. I want to talk about it on a discussion website. And there's no big expensive IT project here. There's just connecting existing things that are happening. So going back to the cartoony diagram, this shows, I think, the five stages that we think an issue might go through when you've raised that issue. So let's take diabetes care in Cambridgeshire as an example. People are not going to say, I think diabetes care in Cambridgeshire needs to be altered so it's more like diabetes care in Suffolk, because people probably don't know what both of those are like. Maybe they do, but maybe they don't. So the first thing that Gather is meant to do is to find the evidence and the people who want to have that conversation. And maybe you'll find that there are other people who want to talk about diabetes care in the same way, and maybe it's actually a general issue about how the NHS handles diabetes. And so you can join up the conversations with others so that you can make sure that everything goes into the most effective place to have the conversation. But also, NHS Citizen will have access to the evidence that's out there. Not just evidence from official bodies with, portcullises stamped on the front, but also evidence from the King's Fund and from research organisations and also from individuals and from previous discussions. So if there has been a discussion in the previous 6 months or the previous year about that issue, you'll be able to see the record of it. You'll be able to see what people said. You'll be able to see whether things changed as a result. And you'll be able to access things like patient opinion and all of the other kinds of services that are out there, NHS Choices too. So Collect, which is the second part, is about bringing together all of the things that you might need to have a really high-quality discussion about the issue that you've raised. And then there are lots of different ways to have that discussion. And Gather, the NHS Citizen site, would provide a place where you could record what was happening. But it wouldn't require you to do everything on the site. You could do it wherever you liked. But the record of the discussion stays in one place so that the next time someone raises that issue, they can see what other people said about it. And it then becomes a library of citizen-generated knowledge about the system, rather than official knowledge or official reports. And that's something that Healthwatch can use, patients groups can use, anyone can use, because it's all open. The penultimate stage is where you refine, because a discussion's great, but as everyone who's been on the internet ever knows, discussions either just sort of peter out into nothingness, or they are sort of finished off by the person who's got the most stamina or the most kind of, or who is the angriest or whatever it is. It's a bit like running a committee meeting by who has the largest bladder and who doesn't need to go to the toilet first. So what we're saying with NHS Citizen is, no, you need to come to a conclusion at some point. But the conclusion isn't these guys win and these guys lose. The conclusion is trying to draw out some thoughts and recommendations, some things that come from that conversation that you want the NHS to hear. And maybe those things won't happen. Maybe the discussion will pick up that there's not a problem, or that people are working on it and it's fine, and that's great. Or maybe it'll say, well, really, this is a community issue. It's not for the NHS to fix this. This is something that we have to do. So maybe it'll end with a kind of an appeal back into the community to say, actually, we think that these are the services that the community needs to be providing, or this is the way that we want people to react in the community. But quite often it'll be an NHS issue. And the refined stage is designed to get to something that is a message to the NHS from that conversation. And the final stage, which is direct, is to get that message to the right place. So one of the things that I know people find really frustrating about public engagement is that people talk human and organisations listen in policy. And having been a policy person for 10 years in Whitehall before I started doing this job, I know that it's frustrating as a policy person to get a human issue which is all sorts of different things mixed together and doesn't really fit neatly into any of the boxes that you're meant to put it in, which is quite nerdy, I know. But, you know, you work in a world of boxes and policies when you're a policy official. But similarly, if you're a human being rather than a policy official, and you tell your story, to be told, well, this bit is our responsibility, but that bit's those people's responsibility, and this bit is those people's responsibility. It makes you wish you'd not bothered. In fact, it makes you angrier about the system than when you had your problem, because you're being divvied up into lots of sort of boxes that are convenient for bureaucrats and not convenient for you. So one of the things that we're taking as a principle with NHS Citizen, stealing a phrase from social services, is no wrong door. So if you come to NHS Citizen with a problem, it's the system's responsibility to get that problem to the right place, not your responsibility to find the right place. And that's something that we have to try to work out how to do. And to do that requires a good system knowledge. So one of the things that we're trying to work out is how you manage that routing within the NHS Citizen system so that it's really seamless to the person who's raising the question. The thing that happens after that message has gone into the NHS is that the NHS has to respond. So sometimes it will say, well, you know, this is why we can't do this, but this is what we could do, or we could work together with you on this. But the most important thing is it does need a response, and the loop needs to be closed, so you're not just chucking your ideas into the void and hoping that someone answers. So each of the ideas that comes out of Gather, as we currently envisage it, will have a timescale within which the NHS needs to respond. And if it doesn't respond in that time, then it will be flagged and it will be raised at the Assembly meeting or with the board, and the board will be the people who are, you know, having to go and knock heads together to make stuff happen. So all of this, as I say, is a very kind of draft system. So version 7, we'll get to version 15, God knows, by the time we've finished. Yeah, and it will probably look a bit different from this as well, because as we work it through, as we talk to people, as we actually test it, which we'll be doing in the run-up to the NHS AGM in September, we'll find all the little bugs and all the problems and all the things that don't quite work. But this is what it looks like today, and this is the model that we want you to talk through today and improve for us today, and think about some of the practicalities of how it might really work. Right, I've talked far too much, far too much, as always. So, any questions? Yes. Oh, you'll need a mic, sorry.
Thank you. Does this work in total isolation from the political framework, the funding issues, the privatisation of the health service, all those sort of things which overlap with the delivery?
No, as far as I'm concerned, it shouldn't. You know, you ought to be. Again, it's back to that question about, you know, no wrong door. You know, you've got to be able to ask any question, because actually all sorts of questions are bound up with stuff like privatisation and, you know, funding issues and so on and so forth. So if you say, oh, well, you can't do politics in it, then, you know, you have a... I think you probably would not... I think there probably has to be something about not being really party political. You know, you don't want someone asking a question that says, you know, why is the brilliant Labour Party not being listened to more when it's trying to defeat the evil Conservatives? Because actually, if it's funded with public money, you can't use it for political party campaigning. But in terms of the issues, I personally think that you ought to be able to raise any question, and that should be dealt with in the right way. Did you want to come in on that, Olivia? Is that why you stood up?
No, I'm just doing miming with Fiona.
Right. Okay. So you know, you have. So my answer is, you can't separate out privatisation and funding from a lot of the concerns that people have about the health service. So you have to be able to raise any issue. Any other questions? Yes.
Yeah, I'd just like to ask or make an observation about work with Health Watch England, because we're at the moment refining how we actually do this. and I think we need to obviously work out how that all fits together. But we've got an escalation process with Healthwatch England that's currently just been set up. So just wondering, just to flag that up, really.
So just to say, that means that if something isn't answered or isn't dealt with, it gets...
Exactly.
That may be how we can... That may be one of the ways we can...
Exactly. They've done quite a lot of thinking about this. And also, it is... I constantly think about capacity in the system and safeguarding, and we do see the impacts of that day to day. So I completely... I'm not quite sure how you can divorce it from the political stuff, but... it's the influencing. I think we just have to be really smart about who we are influencing with what intelligence, because and what's at a local level and what's at a regional level, and what's at a national level.
That's right. And some issues may actually be multi-level and may go to multiple places. Yeah. And then...
Hi. I understand the system. It just seems to me that you spoke about the power of having a patient sit there and tell the board, right, it didn't work for me because of ABC, which I agree completely with. Therefore, it worries me slightly that this refinement process, shall we call it, in Gather, is likely to mean that the person, if you've got 250 people on there, are you going to be changing them all the time so you make sure the person who actually started the voice is one of the people who speaks?
It's a really good question.
Or are you going to end up with people there representing the voice back?
It's a really good question, and one of the things I should have said is that if you've raised that flag, if it's your issue, you own that issue right the way through.
Right, but there could be thousands of us.
There could be thousands of you, and so one of the things about Refine is not to make it, is not to dehumanise it, or not to kind of turn it into policy speak. Is to turn it into a message that the NHS can hear, and that means personal testimony, but also maybe understanding that, a few words about what that policy impact might be. So it's trying to do both. But yeah, you own, the person who raises the flag owns it through the system.
Mentioned about the which door to go through, and one of the things, I won't name the groups because they're not in this area, but I mean I've been to a meeting with one particular Health Watch where people asked questions about the operation they had a month before, and they were very curtly told, "Oh, we don't deal with that. We don't deal with that." And obviously, as you say, they should signpost that person, stop and do it properly, because the person won't do it themselves. And also a clinical senate, somebody asked a question about a pathway, and the answer was, we don't touch pathways, we're not allowed to touch. Well, rubbish, pass it on, speak up. Yeah. And also, when you're in a meeting like this, if you know something's wrong, you must say so, because I believe that what you said is not quite true a few minutes ago. You can, for example, in local authorities, use public money to campaign party politically if you have leave from the Department of Local Government. It used to be the Cabinet Office. And the one where it's used a lot is on boundary changes.
Yes.
And then the other one where it was used was, do you want an elected mayor or not? So basically, you shouldn't have any rules. Just be polite, say what you want. And the trouble is, I started life as a journalist, and you end up as a really stroppy person. Not very popular sometimes with people. No, well, but if you're in the middle... I mean, I sat in a big police meeting, and a police chief officer said, go to your local council, go to the district council, they run the schools.
Yeah, yeah.
And of course, they don't. And, but I was polite enough to wait till they'd finished and go to the person and tell them, rather than in front of all of her officers. Yeah. But, I think people must speak up if they disagree.
Well, and it's interesting. I mean, it's a really good challenge on the point about about just make people be polite. Because if we get through all of the questions, my kind of hidden question that I was going to do at another meeting, but we might have time to do today, is what ought the minimum house rules be to allow the maximum conversation, but making sure that it's a place that people feel that they're welcomed and that they aren't kind of, being shouted down. So I think that if we get onto that, then we can talk about that. And even if not, we'll be talking about it online in other events. So it's a really good challenge. Thank you. Olivia.
Can I just come back on the Health Watch thing as well? Because actually, interestingly, we're also working on an escalation policy. So I coordinate the relationship with Health Watch England and NHS England as well as this. And I think it's important. Health Watch England has a statutory basis. Local Health Watch has a statutory basis. This doesn't. And this is about a way of working, and Health Watch needs to be a part of that, and this needs to connect with Health Watch and vice versa. So we definitely don't see this as a competition thing. And actually, Health Watch England enacting its statutory powers to be able to take things to the Board of NHS England is a very different conversation to an assembly meeting where we might be debating points of perception and influence and idea, rather than the statutory kind of slightly bigger stick approach. And I think we need them all. So I don't think this is an either or, I think it's a both and.
Okay, brilliant. If there are no more... Oh, is there a question? There's a question.
I'm not sure whether this is relevant at this stage, but because you've already mentioned different counties and different ways of doing things, but how do you transfer, shall we say, someone's got a problem with an elderly relative living in one county, but they're responsible for her, but they live in another county, and they can't get, say, the social services in the two counties to agree on a common policy?
I think that's a really good question, and so I'm going to try and keep this short because this is one of the things I really find fascinating about NHS Citizen, and yes, Olivia needs to chuck stuff if I get too excited about it. One of the things that I think NHS Citizen is designed to do, which current politics is not designed to do, is to manage the fact that people have kind of overlapping interests in different places. So you're talking about me, because my mother is in Devon and I'm in Sussex. And so I'm much more interested in social services in Devon, where my elderly mother lives, than I am in Sussex, where me and my, thankfully, so far, healthy family live. So there is a question for me about how, at the moment, the state doesn't recognise that I have any interest in Devon social services. My constituency is Brighton Pavilion, my local authority is Brighton and Hove. They're the people who are responsible for me. So NHS Citizen allows me to raise an issue about Devon social services much more easily than I could do with a scrutiny committee or through a consultation. And so we're designing it in such a way that you can raise issues across boundary, or that are regional issues or issues that don't have a natural home. And so I think, we're hopeful, if we get it right, and this is why we're about to have a conversation about local and national, if we get it right, this will be a really good way of raising the concerns about coordination between, say, Suffolk and Cambridgeshire, in a very, very different way from taking two separate conversations, one to Cambridgeshire and one to Suffolk. Yes?
Thank you. That's very interesting, because I had a telephone call from one of my residents who's got a disabled brother in Surrey, and she wants to move him up to Suffolk. And what I've done is I've put her in touch with my housing team, who have explained her options, which she's going to enact for her brother. And I've also said, in my other role with the county council, I can help her with the social care packages. So that is an example of where a seamless
sometimes work.
Transition can work.
It can happen, but it needs that personal interaction.
Exactly.
Yeah. Brilliant. Yes, go on.
Sorry, that's the other bit that really excites me about this, is how do you share the fact that it is possible to do that? It is perfectly possible to do that because you've done it. So how do you share that and help other areas of the country see that actually this isn't the board of NHS England stopping it or the statutory basis or anything? It's the values and behaviours of the people enacting those policies or the local decision makings. So how do we help people see that it is possible to work differently within the system as it's currently created?
Fiona?
I'd just like to respond to that very point, actually. This is something that came from Kieran Devane, who's a non-executive director of NHS England, and he's also the CEO of Macmillan. And he said, everything that's being done in the NHS is being done brilliantly somewhere. And I think that is such a useful thought to hold in our heads, whether it's the care of, elderly people with dementia, whether it's mental health in young people, whether it's, the provision of dialysis. Everything is being done brilliantly somewhere. People come forward with these kind of case studies and things. And it's about sort of liberating the possibility of doing this a lot of the time. It's about leadership and people taking responsibility, because clearly there aren't really any infrastructural problems to getting everything done right. It's just finding a way of doing it and enabling people to do the best they possibly can, really. It's stating the obvious, but I think it's a useful thought.
I love that phrase. That's great. Yep.
Two short things. I do think I want to use the word nomenclature. I read it in The Guardian in an article about the residential centre 30 years ago, and it stuck with me. But I do think the way in which we name and describe ourselves, and I don't like the word patient. I think too many terms are dismissive. I think about all these discussions, especially the last one about inter-county thing, is made for a rethink, a radical rethink, about the whole notion of a bipartisan trade approach as opposed to a professional approach, top-down, is community development thinking. It's about the transfer of power. It's about proactive networking. It's about grassroots upwards thinking. I think if we can relearn it, and it's been on and off for years, it fits together. I think we are talking about community development theory and practice.
Okay. Thanks, Peter. We have an hour and a half before lunch. Coffee will be available during that period. I want to hand over to Clive, who's going to take the first part of the session, and then after lunch we're going to be hearing about the Citizen Senate. So I will hand over to Clive. In fact, I'll turn the projector off so that we can focus on the flip.
Great. Okay, well, you've heard from us for a bit, or from Anthony, and we've had some Q&A. We're going to get you to do a little bit of talking and thinking on your tables. What I'd like you to do is sort of answer two questions, really. How do we get, you may not be able to see this very easily, so I'll read them all out, but how do we get issues into NHS Citizen in a way that will work for you? And how do we get issues out of NHS Citizen in a way that will work for you? So take the first question there. I phrased it as, how do we bring issues into NHS Citizen in a way that's going to work for you? Now, as Olivia was saying earlier, we haven't built this thing yet. We haven't got something that we can show you and test here around the room. So you're going to have to use your imagination to some extent. And you may still have loads of questions about how this thing would work and what it would look like and what it would mean for me. And that's absolutely fine. And if you've got questions, then that's the discussion you have on your tables. But I suppose it might help you just to reiterate something Anthony said earlier, just to think about NHS Citizen as a way of connecting people, as a way of connecting networks. So, you're in a group, an organisation of individual citizens. So think about NHS Citizen as something that can connect you to lots of other people, lots of other nodes, to use a technical term, lots of other networks. And a mechanism for sort of amplifying your voice and giving strength to the issue that you want to take through the system. So thinking about it as a way that connects you to others, thinking about it as a way that gives your issue some strength, some amplification, some impact. How do we bring your issues into NHS Citizen in a way that's going to work for you? I'd encourage you to think about this very practically. You might want to think about a particular issue that is of concern to you. So you might want to pose yourself the question, well, okay, how would I take this into the system, and who would I want to speak to, and how could this work for me? So that's the first question I'd like you to think about. How would NHS Citizen work for your issues that matter to you? And then the other question is, how do we get issues back out of NHS Citizen in a way that's going to work for everyone? And the way I phrase the question here, I'm going to regret this, because I've put, how do we make what comes out of NHS Citizen work for the movers and the receivers? I'm going to regret using those words. But by movers, I mean the people who've moved the motion, the people who want something to happen. So these are the people who, in the gather process that Anthony described earlier, have raised a flag and want to get an issue sorted. And by receivers, I mean the people within the health and care system, the provider organisations, the commissioners. How would they need to get that issue out for something to happen? So how do we get issues that are going through NHS Citizen out and get them to be actioned, get them to work, get something to be done with them? So again, it might be very practically that you want to think about this. So if you're I mean, we've got a very good mix of folk in the room here today from all sorts of different organisations. People wear, I mean, we're all citizens to start with, but we also wear other hats as well. We've got provider organisations here, commissioners, Health Watch, social enterprises, a whole range of different organisations. So how would, so you might want to think, for example, how would it work from a provider or commissioner point of view? How would the provider or commissioner want to get information out of NHS Citizen? You know, do they want to get recommendations? Is it about finding the right person to signpost stuff to? Those provider and commissioner organisations might think, well, could I get involved in this? Could I actually get involved in the NHS Citizen process? Am I just a person receiving what comes out, a set of recommendations? Can I get involved in the process? So you might want to have a discussion about that as well. And if you're the person who's raised the flag, if you're the person who's taken part in the issue and a conversation about that issue and you've refined it and you've worked on it, what do you want to happen to that issue? Clearly you want action, clearly you want a response. Just think practically about the sorts of things that you would want it to work for you as a person who's raising an issue. So how do we get stuff into the system, into NHS Citizen that's going to work for you, wearing all your different hats today? And how do we get stuff out of NHS Citizen that's going to work for everyone here as well? Does that make sense? And it's not a problem. You'll have lots of questions. You won't know the answer. You might not even know any of the answers to this. But just have a conversation on your table. If you've got questions, the questions that you've got are just as valid as the answers. So we've got about half an hour before, maybe a little bit longer, maybe 35, 40 minutes before we break for coffee. So what I'd like you to do is, in your tables, have this conversation. There are coloured bits of paper on the table. If you could use those to record, just make notes of the things that you discussed. Don't write War and Peace on those bits of paper, but just jot down notes. And when you're done with your conversation, when we break for tea, I'll ask you to put them up on the sticky wall that's at the back of the room there. Issues in and issues out. So the issues, taking issues into NHS Citizen, issues out of NHS Citizen. If you want to actually break out of this room, you look all very comfortable at the moment, so feel free to stay here on your tables. If you do want to go somewhere else, you're very welcome. There's a room over there and there's another room downstairs.
Can I just say, in terms of recording your things with a sticky wall, because we will photograph it, this is really important. It's the most fundamentally important thing of the day. Please, if you're recording your ideas, please
this wall
write
here is sticky.
big like this, so that when we stick it on the wall, like that, because it's magic. If you write really small, we can't see it, we can't photograph it, and it'll get lost. It's going on the wall. It's going on the wall.
Okay, so can I suggest you spend about 15 or 20 minutes on the first question and then about 15 or 20 minutes on the second question, and I'll give you a prompt to move on to the second question after 15, 20 minutes. Okay? Far away. Folks, can I just check, how's the conversation? lots more conversations going on, just one or two. Pete, are we beaming yet? Yes, we are. Yeah, good. Okay, welcome back, world at large. Sorry that you've missed us. I'm talking to the webcam at the moment. Sorry you've missed us for the last hour or so. We've been working in the room here. But we've talked in our tables around two questions. How do we get issues into the NHS system infrastructure or process in ways that are going to work for you, your organisations, yourselves? And how do we get issues out of NHS system in ways that's going to work for everyone? So we'll have a bit of a feedback session now from those discussions. I could pick on tables, but does anyone want to sort of start with... If we start with question 1 and the issues that you discussed on your table, would anyone like to kick off with the issues that you talked about, or any particular points that sort of came out of that conversation on how you take things into the system?
I've got the microphone, I've got the power. I just want to say the webcasting is always worthwhile, because our colleague Claire Cuthbertson, hello Claire, who's watching, who works in Northumberland, is watching us at the moment and going, she's just rung Nagina up and gone, can you come and do this? Can you come and talk to our team meeting? We want you to come and talk to us about this. It's really exciting. So actually that's so powerful in terms of this connectivity around. So Northumberland are listening to your conversations in Cambridge. Just
and
no
probably,
pressure there.
And probably plenty of other people as well. Sally.
Hi. Yeah, because this is a kind of broad theoretical thing, I was talking about an example of an issue, which in my case is type 1 diabetes and insulin pumps, which are hard to get for adults. Now, insulin pumps can potentially save the NHS a fortune, as well as being good for our health, and I feel very strongly that they should be easier for people to get. What I was thinking about this process is, at the moment, I wouldn't know how to raise that. There's a charity I could campaign with, but I mean, basically, I feel that if I were to go to anybody I could think of in the NHS, it would go up the hierarchy to a consultant. I might even cause myself problems with my healthcare for causing trouble. I wouldn't know how to access or how to be heard, and I'd assume that I wouldn't be heard. So it was really just to underline that at the moment the situation is quite bad in terms of raising issues. So if we can find some ways of making that easier for people to access, then that would be great.
That's a really helpful reflection, and I suppose that one of the learnings for the NHS citizen model from that is that, because we haven't got the thing to show you, as you said earlier, something to actually demonstrate here, we just need to make access into NHS citizen very straightforward and very simple, and it needs to be very clear routine so people know how they can take an issue and people feel confident and comfortable that they can take an issue and raise it and take it through the process. So great, thanks for that.
And just the other bit I heard you say was about safety. And when we were in actually it was Northumberland, so Sunderland, wasn't it? It's personal safety in terms of confidence that your issue will be dealt with without fear for your own care is really, really important. And I think we don't recognise that enough in terms of people's willingness and confidence to raise issues.
Yeah. Thank you.
As this is a conversation, to respond to you, we also had a conversation not too dissimilar, and one of the things we were saying was we seem to be asking the public to have this paradigm shift, but we need to be sure that there's this paradigm shift up above that will respond appropriately.
Yeah, can I just add some comment on that particular point? I mean, we didn't talk much about it earlier, but actually a very important part of the work we're doing on NHS Citizen is a stream of work that we're calling relationships and culture change. So for us, a really important part of this work is supporting the NHS as an organisation to actually understand how this could work, to help change behaviours, change attitudes within the system, so that this has a better way of working with the NHS. So for us, supporting the NHS to do this differently is actually a very important part of this model. So yeah, thanks for that point.
The reason that I've decided to come and join NHS Citizen is on behalf of people with mental health, is because the only way that we were able to be heard is to actually take over our clinic and take a stand.
and now they have brought out a consultation paper. But it's taken a lot of hard work, and it would have been so much easier if they had actually been up front and talked to us in the first place. This would have never happened. So I'm quite interested to see how that would work with NHS England in making sure that this sort of situation doesn't happen again.
Yeah.
And finding out how there is some way of making trusts and CCG held accountable for some of the things that they do. Because I think that is very important.
Yeah.
I really do.
Yeah. Yeah, it's a really good point. I can't promise that NHS Citizens will change the system overnight, because it won't. But people will still need to protest and still need to sort of take action if they feel that's appropriate. But this is a mechanism to hopefully start to change that system, if you like, and make it more responsive to people's needs and voices. Thank you.
I'm glad you're back, because I was going to talk about our conversation. But I think that our table was beginning to address that problem. We are convinced, Fiona and I, that the Citizen Senate is the answer to a lot of these issues. So we talked about what a diverse group of patients and people have come together to form this Senate, and how we draw widely, not on just individual experiences, but on thematic experiences as well. And we've been able to identify some priorities that are meaningful to all of us. They're meaningful to people with diabetes, they're meaningful to people with learning disabilities, they're meaningful to people with long-term conditions. And it's avoiding that kind of rawness and challenge when sometimes people are not able to frame their issues and their questions because you've got this big supportive network. So I think it's a model to be really sat up and looked at and listened to.
Yeah, thanks for that. Yeah, we're really looking forward to the session after lunch with the Citizen Senate, because I'm sure there's loads we can learn from how you've done it within the East of England here. Absolutely. There'll be lots of learning to take from that. So another interesting point about confidence as well, being able to sort of take things forward as well. I like that point.
I just want to echo, sorry, never give me a microphone, I talk far too much. But this whole thing about the culture change, we tend to end up with quite an adversarial and sort of pole position. We think this, and paid people, NHS people, I generalise massively, end up putting a barrier up because they're being shouted at. They don't know how to respond to it. They don't necessarily have the skills or the confidence to respond to it. So how do we skill people up to have a different conversation where we're not shouting at one another, but we actually know how to talk to each other? And that's the challenge. So the Tavistock Institute is one of the partners in this programme, are doing some detailed looking at that. And what do we as staff need to do? What are the skills? What's the support? What's the development that we need to have a different conversation, so we don't end up where you've ended up, Anne, but we end up in a conversation about, so how can we do this together at the beginning? Yeah. And that's massive.
I think on this table, one of the things we wondered was, how do we make people who are hard to reach groups of people, how do we give them access to NHS Citizen? And just wondered how other people did it in different parts of the country.
Okay, yeah.
It's a different point, but the mic was nearby. We had a conversation about the framing of this and whether a positive framing in terms of this really being about gathering ideas about how to improve and would actually bring in a kind of wider range of people. And so, basically how important the framing is. And certainly this table seemed to come alive when it was about a means to gather as many positive ideas as possible.
Yeah, so two really important points there as well. I'll just respond briefly to those before we just go to the next comment. Access to the system, we talked about this earlier. So we need to make, we need to make access to NHS Citizen very easy and very straightforward. And actually, this isn't, as Anthony said earlier, this isn't about creating something completely different and new over here. This is actually about connecting up all the different sorts of things that are going on already in localities, in patient groups, in senates, in health watches, and allowing all those different sort of groups and networks to sort of connect with each other more effectively. And in response to the point, response to the point about framing this and about sort of having solutions to problems, that we've been, that's a really important point. And just to give you a little bit of a tale of our sort of thinking when we've been on this journey of this thing called NHS Citizen, we started off thinking very much in terms of this is about holding the system to account. And actually that still remains a very important element of NHS Citizen. We don't want to lose sight of that. But actually what's become more evident to us as we've gone along is that actually this is also about, and sorry to use the jargon, but sort of co-creating things together, co-designing things together. So working on solutions to challenges in the system together. And we experienced this at the NHS Expo when we had some board members with a group of folk at NHS Expo looking at the issue we talked about there was access, so people getting access to health services and the barriers that people can experience about how they get how they get the service they need. And actually we had a really interesting conversation. The board members heard people's personal experiences, and there were some folk there from an organisation that supports people with learning disabilities, and there were some folk there with learning disabilities who were expressing their experience of barriers to the system. And because the board members could sort of see the problems people were having, we were able to have a discussion about, well, how can we solve this? How can we best design the system from the ground up? How can we best design access to the system from the needs of the people who find access the most difficult? So it was a really helpful conversation. It helped the board to think, okay, when we design access, we need to think about the people who find access the most difficult. We need to design it from their perspective. And if we get it designed from their perspective, it will actually, by default, then be accessible to everyone. So it was an example of sort of co-design in action where people came through to a better way of doing things because they were actually sharing experiences. Sorry, that's enough of me talking. Another comment.
Can I just do the most important bit of that conversation was it has actually led to action. So the specific action was Sean Webster from Change People stood in front of Tim Kelsey and went, but I don't know what NHS Choices is. You've told me everybody uses it and I should go there. I don't know what it is. And he doesn't know what it is because it's not accessible. But it is accessible if you're an IT speaker because it meets all the access IT geeky standards that I don't understand. It doesn't have any easy read. It doesn't work for screen readers. It doesn't work for providing information in a way that Sean could understand and access. As a result of that, the NHS Choices team are now working with us and with Change People and with other user-led groups, and we're going to have a proper review of all the content. I'm looking at Vicky a bit, actually. All the content that's on Choices. It's really quite awesome. I nearly burst into tears in a meeting because suddenly they understood what we were talking about. But that happened because of a public conversation between somebody who'd been supported as a self-advocate and had the confidence to speak for himself, to share his experience with somebody who's in a position to do something about it. And it's really, really powerful.
Great, thanks, Olivia.
Okay. One of the things that we were talking about was, and it builds on a couple of points that have already been made, but is the ability of it to be able to link people up who have got similar, and we weren't using the term issues, but we were talking about experiences. And that's actually made me think that something, we didn't discuss, but is actually the potential to link people also right across the country. So, you know, your experience about diabetes, Sally, was actually, it might be really hard to find somebody with the same experience who lives locally, but there might be 10 other people across the country who are having similar. So actually, it's got that ability to be able to reach out and provide the sorts of support that actually I'm not alone in this, there's somebody else. So I think it could do that as well. So the support nature of it could be something that's quite important too.
Yeah, brilliant, thank you.
Just to add to your conversation, Olivia, isn't it, is also more disadvantaged people like the deaf-blind community also. So I hope NHS Choices are giving consideration to that. And in the broader picture, how do we actually market whatever we set up across the board so people understand what it is and then are enabled to use it effectively? And I think that's a key point because often, even from my experience with information produced, it actually doesn't communicate to people out there,
Yeah.
this is available to you to enable them to access it. So this system needs to be understood by the wider audience who are not able to, use IT and so on.
Yeah.
But there are wider ways to use the system and not one model fits all type of thing.
Yeah, thank you. That's a really good point about communications. We've been on a journey ourselves with communications on this project, and there's more to go. Very good point about communications. Any other comments from question 1 then, how we get issues into the system before we move on to question 2? If you're burning to add something in, now's your chance.
I just have to say, sorry, you have to go look at the Accessible Information Standards works. If you Google Accessible Information Standards, you'll get to a page on our website where we've been hosting a whole load of workshops. This will lead to a mandated standard for information that sets the standards about what needs to be provided for people with communication needs. It's really important.
Great, thanks, Olivia. Oh, okay, a couple of hands, and Anthony.
Point from the World Wide Web.
Yes, please do.
So Mike Clark says, what is the NHS Citizen team doing to engage social care and the social care sector? And I think that's a really interesting question, because it's not the NHS, but actually if we're serious about no wrong door and every question getting to the right place, we need to be able to work with the social care side as well. So I thought I would... it's just a thought into the room rather than necessarily a question that needs an answer right now, but I thought I would bring it in.
Yeah, another really good question, quite a big one as well. Fiona?
I think that NHS Citizen really has to be different from virtually everything else, really. It can't be another talking shop. It can't be another piece of this really, really complicated, bureaucratic system that's the NHS. And we need to be, I hate to use the word agile because it's become such an overused word, but we need to be able to kind of move quickly and responsively to issues, and we shouldn't be hamstrung by this idea of the tyranny of evidence, because some things are so obviously wrong and so obviously need fixing. We talked about hospital car parking. It's an issue for everybody, and you can understand why it might be necessary to charge some money, but it's also a real issue for lots and lots of people. Stuff like that, stuff where there is clearly an issue, and what we don't need is a review body and research papers being required that will take 18 months or 2 years to bring something to fruition. We need to be able to say, look, this clearly is an issue, let's just all acknowledge it and try and fix it.
Great, thanks, Fiona. I wonder if people did talk about evidence on their how do we get issues out of the system, but we'll come to that in a moment. So I'll just take two more points on the first question.
It's about the business of making sure everyone knows it exists, because by and large, as Healthwatch, we're trying to make sure everyone in Suffolk knows we exist, and we're lucky if there are 4,000 people who know what we are. I would guess. We've got 3,000 members, so at least 3,000 should know what we are. But, it seems to me the best thing you can do is go and talk to the script writers of EastEnders, the Archers, and people of that nature, and get a whole thing in there about some disaster that happened that came into EastEnders and went to citizens.
We have some Archers fans in the room.
But you see what I mean? I mean, that's a popular TV programme, and there are others, obviously. So, and people watch them, and they're going to they're going to see it. Adverts, no one sees adverts these days, do they? We've all got recorders.
Yeah.
You record everything, you blast through the adverts, or you go and make tea or whatever. No one.
Yeah. No, a really
I don't
good.
know why the advertising industry is still using television.
A really good tip will be on.
No, but we could do the Archers. Please, can we do the Archers? Will someone give us permission to do the Archers? Will someone write us a storyline?
I'll take 2 more points.
You can be on the Archers, it's no problem whatsoever, but it's paid product placement with the BBC. Charities actually pay to be mentioned on the Archers, and EastEnders and that, and on the news you can have Health Watch on the mugs they drink from and things like that, but sadly it's all paid product placement.
Okay, these are great ideas, thank you. One more point.
How do you do visual product placement on the Archers?
Olivia?
I'm going to get disruptive.
Thank you. Just last one. Another concern is we've got this opportunity to create this new design. It has to be sustainable, because after all this work going on, and we're version 7, it might be version 15 by the time we're we've produced something, it would be a shame to,
Yeah.
you know, for it not to exist.
Yeah, yeah, really good point about sustainability. Okay, so you had another question which was to think about on your tables, which was how we take issues out of NHS Citizen and how we make that work in ways that are going to work for you and for the organisations who will be receiving that information. So let's get some comments on that conversation. Just to alert you, we're going to break at 12:30 for lunch, so if you're getting really peckish, then you haven't got long to wait. But let's get a few comments on question 2. So,
our table talked about maybe having feedback from it or throughout the process, so if it is taken regionally instead of just locally being told, and then if it doesn't go nationally, being told why it's not, what's going to happen. And we also thought it kind of need to close the cycle of it, of having a review process at the end. So after it's been done, there's actions made. Has it actually worked? Has it made a difference, or has it been a short change and not lasted?
yeah, thank you. Two really good points. So feedback on what's being done, and actually a sort of an evaluation of actually has the process been an effective one. So, Anne at the back. Oh, okay, I'll come to you.
Just following on from that, actually, it's about tangible outcomes, isn't it? About when you say about the feedback and how do you actually monitor the process while the particular thing is ongoing, and to see the outcomes from that. Yep. Because so many things I've been involved in the past, service user involvement and representation, you don't always see the outcomes, the projects, the funding dries up or whatever it might be, so you just don't know whether you really have made a difference. And then another initiative comes along and people get involved again, and again the same cycle just repeats itself. So if we could have effective monitoring and see the outcomes, I think we'd really be making some fantastic progress.
Yeah, it's a really good point.
Hi, we had a similar thing to the young lady over there, so she's answered one. But the other idea that we had was we quite like the idea of the open library, where if you deal with some issue and then a couple of years later someone else comes up with a similar issue, then the answer is already sort of there for them. Yeah. So the open library idea went down really, really well. We thought that was a really good point.
That idea came from someone who's a librarian or an ex-librarian at the Leeds workshop a month or so ago, and we all thought, and it was just such an obvious and a good idea, and really a really good one.
I'd just like to question the idea of an assembly. If we have adequate monitoring and publicity about that, I don't actually feel the need for actually people. You said it's been very effective to have people like board members listening to real experiences. I mean, I've attended groups where a patient, it's called a patient story, has been talked about. It's often, heart-wrenching, the things that have gone wrong. People listen, they don't do anything about it, and for somebody listening, it actually feels exploitative. I don't really see the reason for people to actually say the things face-to-face with a board or a facilitator or a participation officer. Is there another way of actually getting the voice heard, which isn't so personal as that, when many times nothing happens?
Yeah, that's another really good point. And sorry, was there another point on that particular? Yes. Yeah, go ahead.
Thank you. Yeah, absolutely. I mean, that's something we picked up from Healthwatch, and just a couple of things on that. I think actually it is a good thing that especially boards of governors, the providers, actually have a patient story at the beginning of their meeting, because then it actually reminds them why they're there. And I think it's really... Well, and that's the next point, is the fact that we're bringing out guidance, which we're going to be publishing soon, which will be actually saying, number one, this is incredibly sensitive, and only people that actually want to do it and know what they're doing should be invited to do it. They need support all the way through. They need feedback. There needs to be actions taken from the patient's story, and they need to be fed back to the person as well. Yep. So as long as it's done properly, I think it's incredibly powerful, but I share your concerns if it's not done properly.
Yeah, absolutely. Things leading to action is a key feature of NHS Citizen listen for us. And just to say on the assembly, we are planning to do a full test of an assembly in September. So if you're interested in the assembly element of this, do express an interest and get involved in that process, because we're planning that now, and we're going to run an assembly session in September and see how it works. And a lot of these issues around how comfortable people will feel about speaking before the board, all those practical issues and concerns, hopefully we'll sort of explore them at that test. So there's some more comments, Eddie.
Okay, that just leads me nicely into accountability. And I think in terms of feedback and everything, if the job hasn't been done well enough, then somebody has to be accountable. And going by this chart, if certain issues are passed on to different providers or so on, and nothing happens with it within a certain time limit, then where is the accountability? So I think that needs to be factored in.
Yeah, absolutely, yeah.
I suppose one of my problems is in the second or third hour, a really nice day, and I'm still enjoying it, why we haven't got people from the most powerful groups, medics and the whole range of people who make up the whole concept of caring, healing and curing. I find it very strange that, and Shaw of course said that the problem with professionals is there a conspiracy against the laity, and I think there's a certain amount of, unless we can get a more egalitarian approach in terms of the debate, we're ignoring, whether or not we like it or not, the most powerful people at the centre of the debate. And my second point is, I've got to stubbornly to this view about the narrow concept of NHS. We know from the Black and other reports, and we know from the work where medicine began to think about the societal nature of after-war processes with the Henderson Hospital and Dingleton and Maxwell Jones, who used to create a therapeutic approach where the cost of medicine went down, where the participation rate of people went up, because you started dealing with social issues such as employment, such as housing, about one's role and view of the nature of society. And if we ignore this, if we become too ultra-clinical, for example, we come unstuck on the more pluralistic areas.
Yeah, that touches a little bit on the point that was made earlier from outside the room about social care and where's the sort of interaction with the wider care health system here. Okay, so any more comments? I think you're all desperate for your lunch, I'm sure.
Yes, well, I'll make this as brief as possible. But there is a hospital in Cambridgeshire which, I hate to bring up the fact, that has private administrators, not private medicine. And one of the things they have done is to make the chief medical officer the chief executive. And so consequently, if a problem comes up, it is discussed at a board meeting where the public are at, and also it is also stated what is being done to solve this problem. And 9 times out of 10, it's been working. Now, that's on a much smaller scale. But as somebody, I think, said earlier, the separation of medicine from administration is probably one of the most difficult things to solve in the NHS, isn't it?
They're two really helpful reflections about how the system works and power bases, if you like, within the system. That's really helpful. Okay, I get a sense that people's tummies are rumbling. I can't hear them, but I get a sense that they are. Mine is. Sorry, Olivia.
On that last comment about professional groupings and I suppose staff in general, that we've had a very loud and constant refrain of actually lots of, well, obviously staff use the NHS as well. Staff use social care services, staff are carers. So how do we work with that in terms of who is able to participate in this? And I completely hear you around actually the power bases in the royal colleges and the professional groupings are often those that maintain the status quo. So how do we bring them into this conversation where it is about moving towards a whole person and a whole community rather than retaining those siloed approaches that just perpetuate what we have now?
The most powerful trade union in the world, of course, with the BMA.
Yeah, let's not go there. Should we have lunch?
Okay, so Just before we break up, Anthony, what time are we going to come? Are we convening back in here?
I think 1:15 ideally, just to make sure that we've got enough time for this afternoon's conversations.
Okay.
Yeah,
great. Yeah, okay. And where's lunch?
Across the way.
Okay,
so
lunch is just the room where you had your tea and coffee in earlier, and we'll
No, it's not. It's on this floor, I think.
Yeah, there was tea and coffee in there earlier.
Oh, was there? Oh, fine.
Yeah,
fine.
yeah.
So, yeah. Tuesday.
Yeah, and we'll reconvene at 1:15. Okay. Thank you, folks.
We'll try. Thanks very much. We're just going to get started now for the after-lunch session. As I said, we will absolutely, definitely, 100% certainly be finished at 4 o'clock. So, there's one thing that came up over lunch I just thought I'd mention, which is, someone was just talking to me about over the lunch break, which is how do you make sure that you're not kind of sharing sensitive information, or that you're not kind of associating stuff with your identity that you might worry about, given that, the internet is... we're talking about something that's there, that stays for a long time, that is referred to in the future. I don't want to go into too much technical detail, but one of the organisations that we're working with is called MyDex. You can look them up online. MyDex work on personal data stores. So the idea behind NHS Citizen is not that the NHS owns a big database of all of the stuff that people have said and who they are, but that you own your data. So that the things that you say and your identity is entirely under your control, and you can withdraw permission for NHS Citizen sites to use it whenever you want. So I won't go into it more. I have to say I am not the technician in the team, it's fair to say. The technician in the team is elsewhere today, but we can answer any questions about those sorts of issues. But I just thought it was a really valid point, because a few people have said, oh, well, isn't this a kind of slightly creepy sort of NHS knows everything about my personal views database? And the answer is, no, it isn't. But we're working on lots of ways to make sure that it is extremely secure and that you don't have to use your actual real identity if you want to use a pseudonym, but the personal data store allows us to know it's always you. Okay, so I'm going to talk very, very quickly, introduce very quickly the next session. The conversations that we were having before lunch were about the kind of the going into and the coming out of the system in quite a general way. What's the right way for stuff to go and what's the right way for stuff to come out. One of the things I want to focus our conversation on during the afternoon is how it might work in the specific environments that we have here in Cambridgeshire, Hertfordshire, Suffolk, Essex and so on. How does the regional and how does the local play into it? And we're really lucky in Cambridge, and one of the reasons that we're here in Cambridge, apart from the fact it's a beautiful city, is that the Citizen Senate for the East of England was one of the first groups to start thinking about how they can bring together all of these regional patient voices before even we'd started with NHS Citizen. So, so we met Justine at the first event that we ran in October last year, and they clearly done a lot of thinking and had a lot of great networks. So I thought it was great. I thought it would be brilliant to give the afternoon session to them to talk about what they've been doing, but also to try to work out collectively how those sorts of regional and local initiatives can play into NHS Citizen and how we can support each other. So Justine and a couple of the team are going to be talking a bit about it. I'm going to hand over to them. But that conversation is how we're going to spend the big chunk of the afternoon. And we will at some point be joined, we assume, by Victor, who's not answering his text. He's gone AWOL. He's loose in the city. Anyway, I shall hand over to Justine and colleagues, and we'll be talking about local and regional for this afternoon.
Oh, okay. Can you hear me, everyone? Okay. Is this on?
They have control. You have no control. It's all them.
You can switch me off then when I'm going on too long and being very boring. Okay, I'll try not to. Hello, my name's Justine Thompson, as I said earlier. I am a patient. I somehow ended up being employed by the NHS. I don't really know how that happened. I regard myself as a sort of patient, really, and a patient advocate, and I want to get patient voice into all our systems and services so that we can actually work together and make things better. And I also, in another way that I don't understand, I ended up last April 2013 being the patient and public participation lead for the Strategic Clinical Network and Senate, which nobody knows what that was and is, and we're still struggling with trying to work that out. And I thought, gosh, I've got this job title and there's no job description and I don't know what I'm supposed to be doing. What on earth shall I do? So I called on two good friends who are in this room today, actually, which is Fiona and Tony, that I'd worked with in the past. And I said, help. What are we going to do? There's all these new bodies. There's Health Watch. There's area teams. There's strategic clinical networks. There's academic health science networks. Nobody knows what they are. More importantly, we used to know how to influence people, and now we just don't have a clue, frankly. We know who to go to and who to speak to. So they've both got bigger brains than me. In fact, everyone in this room, I'm sure, has got bigger brains than me. And we drew a lot of stuff out. And I'm going to move these. How do I move these slides? There. Oh, it said it doesn't work. Space bar, not the down button. They're not responding. Not just me being an idiot. So, this. Okay, sorry, technical issues. So, yes, we got together with Tony and Fiona, and then we got a bigger group, wider group of patients and carers and members of the public together, and we sort of drew out all these bodies and said, how are we going to connect all this up and how are we going to influence? And I won't bore you with the whole story, but we came up with the Citizen Senate, and the idea of the Citizen Senate was that it was set up to connect and support what we now call public voice. I don't think we did then. Public voice in the region. To make the voices of people in Health Watch, people in local PPGs, people at CCG level, to try and enable them to be heard at regional level, and then hopefully by potentially connecting with things like NHS Citizen at a national level as well. And also to support people. We heard this morning that there were concerns about the safety of people getting involved in this, but it's also a mechanism to support people who want to be involved and want to be heard, but they might find it difficult or they don't know where to go. So that was the idea of it, really. Yes, and what we identified at a very early stage was that there were routes for this at local level, so there's Health Watch at a local level, and there's things happening nationally, but actually where was the regional public participation? Okay, I'm going to try and move it again. And this is a sort of diagrammatic form that we came up again at a fairly early stage with what was feeding into it, really. So we realised that there were people we'd have to reach out to, homeless people, black and ethnic minority groups who may not want to come to meetings, people who work during the day, and we have our meetings during the day, or at weekends and they still can't come. So we need to reach out to people, but we also needed to potentially look at surveys that were going on, to reach out to charities, to be involved with academic health science networks, and to reach to all the patient groups and to get that fed into the Citizen Senate. And I'm now going to pass over to somebody who's very good at explaining how all this sort of programmy stuff works. She said, looking at Trevor. Trevor Fernandez is one of our two co-chairs who were recently sort of elected to the Citizen Senate.
Okay, thank you, Justin. I think I ought to explain that before I came on board, Justin and Tony and Fiona did a lot of the hard work. And she says that she's struggling. I don't think she is now. I think they've done an amazing job just getting the Senate set up. And I think everyone who knows me knows that I'm quite cynical and quite hard to convince. So I can honestly say that this actually feels that it is working. So let me explain. If I can, what is it, spacebar or? So who is the Senate made up of? We've got a number of our membership here, but these are people, these are ordinary people. I say ordinary, but I need to qualify that. These are patients or carers who have had, to me, I always find people's careers amazing. And some of these people have had amazing careers, but what is really more important is their experience of being a patient. They are having long careers and they're very erudite, but they bring a certain value to the Senate. And I think this is the thing that makes it all work well. And this is the thing that I'm excited about. Some of these people are associated with other organisations, lots of patient groups, so you can begin to see that they bring quite a lot of insight to the Senate. So how do we convert all that information and that insight into actually producing good outcomes for patients? Well, what we did was we drew up a list of 12 strategic priorities, and from those the group collectively voted and we scored the preferences that we all agreed on. And at this point you need to remember that all of these people who are scoring this have brought insight to the Senate. They have all, again I'll repeat, they've all come from backgrounds where they're either patients or they're representing patients in support groups, etc. And we came up with 3 priorities. And so we can quite safely say that these priorities are a good representation of the East of England. Is that fair to say? We think so. We think so. So, you know, there's examples up there. Equality of access, something that's always bothered me, is in its literal term, how do we get peoples on the fringes of society to get involved, and how do we look out for them? Many years ago when I was a boy, I don't think the NHS was good at that. So I think we've still come a long way now. Prevention of early diagnosis in primary care. This is a hot topic at the moment. And we know that GPs, when I talk to my GP about this, it's still a challenge to try and correctly diagnose with somebody with multiple conditions, and very often things are missed. So we need to focus on that. And community care and integration. I've talked to some people here. I've talked to this gentleman, not Peter, about social services and why our health services and social care are 2 different organisations. So I think we've got some priorities there to get on with. What I will say is the next step is the important thing, because having done all of this work, we now need to somehow try and influence the plans of the commissioners and the clinical commissioning groups and the strategic clinical networks to try and adopt some of this, or at least to influence it. So I shall now hand over to Fiona.
Yes.
Is that one you want?
Yeah. I haven't seen that slide before with words on. Oh, I don't need this one. Okay. I think we've come really quite a long way, actually, with the Citizen Senate, because it started just as this kernel of an idea of something that we might do, and we've brought it quite a long way in about 12 months, really. The people in it are a really interesting cross-section of people, and as Trevor said, with the most amazing wealth of information, experience, expertise, really good skills, really good networks. One of the things that we definitely are is a network of networks, because there are people in in various support groups for long-term conditions of various sorts. There are people connected to Healthwatch and other stakeholder organisations, hospital trusts, the Academic Health Science Network as well. And they're also just very kind of skilled and savvy. So it's a good, really excellent bunch of people to bring ideas and issues from, you know, a very wide range of places. And I think what's worth considering is the activities that we have been doing, which has been, in quite a short time, to look at a broad range of issues and to discuss them in a really useful, productive, supportive environment, and then prioritise the ones that were of most importance to most people, in order then to take those up. Now, one of the ways we're doing that at the moment is by trying to map those against other pieces of work that are going on across the strategic clinical network. So already we're starting to look at how we can take those things forward and who with and how. We're also kind of winning credibility and respect within the strategic clinical network. We're sitting on the geographical oversight group, which actually sort of says yay and nay to quite big money spent, which is quite frightening, really. And are working with various groups of people. We've also got 3 people sitting on the clinical senate. The doctors, all these consultants on the clinical senate, were a bit leery, really, about us turning up, because I think the experience, I think, for clinicians is that if they haven't worked with patients and carers, and if I say patients, I do mean patients and carers, it's just shorthand. If they haven't worked with patients, they're jittery and nervous and a bit defensive. You talked about that kind of blocking behaviour. Because they're worried you're just going to come and whine about how long your mum waits for a prescription or something, and just, you know, be a terry with a particular issue. But the experience that came up through the Anglia Cancer Network and then has come through all this, and is the case in lots of other bodies across the country, I think, is that actually once they sit down and start to talk to you, you win respect pretty quickly, because they understand that in the end, we want the same things they do. You know, we want a better service for as many people as possible. And that by working together, we can influence that really usefully. So we are, you know, gradually winning this respect and credibility, I think. But I think in terms of this, pretty pictures, and when you look at the things that need to be going on there and the activities that need to be taking place, I think we're actually doing these to some extent already. We're already doing the discovering and the gathering. She said, looking at the words to make sure I've got them the right way around. The discovering, the gathering. We're doing this by, you know, because our membership has fingers in so many pies across the whole east of England. We've got such a lot of experience, such a lot of contacts, that we can do that. We can discuss them usefully, like grown-ups in an adult environment. Not entirely adult, that is to say, young health ambassadors are part of our Citizen Senate. We meant to say this earlier. Can I introduce Alex and Tara, who are young health ambassadors? So we're obviously trying to bring young people into this adult conversation as well. I'm not suggesting you're not adults. But we're doing discovering, we're doing gathering, we're doing the prioritisation, then we're trying to map this to activity that's going on already across the region by working with the strategic clinical networks. You know, I think it's not perfect. This is far from perfect. We haven't cracked inclusion, but as we've said before in other environments, we've been trying to crack social democracy and representation for 350 years, and we haven't done that. You know, we aren't going to solve it for this. We shouldn't let it hamper and hinder what we're trying to do, I think. What we have to do is be really conscious that it's an issue, really conscious that we have to keep doing our best to go out to groups, to go and find where people are and so on, and be very, very serious about that. You know, no messing about on that one. So as I say, it's far from perfect, and there's still, you know, lots we ought to be doing and lots we ought to be doing better. But if you think about what needs to be happening for NHS Citizen, I think we're ticking a lot of boxes, really.
we've got this great connected group of experienced, savvy people who are capable of bringing issues together, prioritising them, feeding them upwards. We said quite a long time ago, if we didn't exist, you'd have to invent us. You know, I think there's a case for saying that something very like this body could easily exist right across the country in the different regions, and that there could be a network of clinical senates feeding into the NHS citizen. I said clinical senate again, didn't I? Sorry, I keep doing that. Citizen senate. No, I'm on the clinical senate, so I'm easily confused. We've got a citizen senate, and I think a network of citizen senates acting as hubs to feed in to NHS citizens might well be a good way to go. So what we'd really like to do is talk about this. We know it's not perfect. I'm sure you think it's not perfect. But we might think about how something along these lines might work, might not work, how we could take it forward, how we might go about establishing them across the country as well, if that's what we thought needed to be done. That's it, I think, really.
Okay, so, Pete, you might be up. So, couple of opportunities for questions first. Did you want to?
Because I've sort of been, I've been involved in seeing it develop. So I've had the privilege of sort of being involved, but not involved, if you see what I mean. And I just wanted to say on the diagram that you've got, which I think has really made it successful and able to achieve a lot in a really relatively short length of time, is this bit of your diagram which is about respectful relationships and engagement. And I think that the whole way that it's evolved and developed has been those relationships that have developed. So I just wanted to add that, if that's okay. Oh, sorry.
I was just going to ask you if... Is that... Oh, yes, that turns on now. So this thing about could this exist, could the Citizens' Senate exist in different regions around the country? There is early work happening in the West Midlands as well. The South West are doing something as well. I just wonder, I know you know about the West Midlands one, Mary, so could you just mention a little bit about where they're at? Because they're taking a similar and they've been connecting up, but it's a different approach.
Yes, so they're building on some, in the same way on some of their established clinical networks, and actually are taking a very similar approach, because I think the real advantages of the approach are about asking people to apply and recruit and then developing it together. So that's the approach they're taking. So I think where you've got on the thing, I sort of don't quite agree with your final thought on there. Maybe if we didn't exist already, you would have to invent us. I think it's people working together to develop that rather than inventing something and imposing it. So building on what's there and what works, and taking people's interests from there. So they're taking the opportunity to do that in the West Midlands as well. And hopefully the East Midlands.
Okay, so just really quickly, you might be thinking, well, hang on a minute. I thought we were here talking about NHS Citizen. Now we're talking about this Citizen Senate thing. I think this session is an opportunity to talk about how all of these things can connect up. So first thing, I want to take some questions for the Citizen Senate team or questions for the NHS Citizen team about more general things. And then I'm going to ask you, much like we did this morning, to think in your tables about how these local issues can be picked up and how NHS Citizen and regional bodies like the Citizen Senate can work together at local level. So questions first, though.
I'm even more confused about why we're here today. I've never heard of the Citizen Senate, and I'm very interested in NHS work, so I would have thought I would have been informed about it. You've described the process of it, but you talk about elected members. You're talking, I mean, is this an organisation? How does this differ from your aim, your vision of what the NHS Citizen is? Nowhere does it say the aims of this are to do this, the aims of NHS Citizens to do this, the aims of Health Watch is to do this. How they overlap, you seem to be you know, it was invented, introduced by saying, are we reinventing the wheel? I just find it all so confusing, and, you know, having been part of NHS management in the past, it all seems very familiar that we've got yet another group setting up to do another thing, which overlaps with another group, which overlaps with another group, and actually we end up by getting nothing done.
Okay, so I'll answer part of that and then pass over to the clinical senate, citizen senate. See, I'm doing it as well. So the point about NHS Citizen is not that it's meant to replicate other groups. It's meant to overlap with them in the sense that it's meant to try to connect them, so it needs to be able to work. It needs to be able to understand what's out there. So things like the Citizen Senate, but also things like Health Watch and other organisations ought to be able to use the infrastructure of discussion and connection that NHS Citizen provides so that they can be more effectively joined up. So that's the point, really. So to say NHS Citizen is overlapping with this, that and the other is right in a way because it's meant to be connecting the pieces together. What it isn't trying to do is to replace them. So we are not trying to say, oh, well, we're the new Health Watch or we're the new this, because actually we're really not. We're actually meant to be an infrastructure and a method that connects those pieces together. And the Senate is a great example of the sort of thing that might happen in a region in the same way that Diabetes UK or that a patient group or that PALS might use NHS Citizen to connect up their conversations. Then the Senate can be one of those organisations as well. But I'm going to let them answer the question as well before coming back. Sorry, otherwise posterity will not record your question.
I'm sure they won't miss it. I'm unclear about what the structure of this organisation is, whether it's funded, it's obviously got elected members, it obviously sits on various bodies. I mean, what is it?
That's the Senate we're talking about, so I'll pass it. Yeah.
It's a good question, what is it? But we're a bit similar to that, what Anthony just described. We're a network of networks. We're not an elected body, and I'm sorry, apparently I said elected when I should have said appointed, so forgive me. It really is just a network of patients from other patient networks. And yes, I appreciate that not everybody has heard of us, and that's because there's really just me and the people on the group, and we did a big email round with the help of Mary's team, actually, to all the voluntary sector organisations and everyone we could get contact details of to say this is happening, would you like to be a part of it? But I'm quite sure that as there are 5.8 million people in this region, we didn't reach them all. And I know we didn't, and hands up, I just can't. There is just me, literally. We don't have a web presence. That may change. We are hoping that this is an idea that will grow and will reach more people, but it's a process, like NHS Citizen is a process. We are not a done deal. So I hope that answers.
Any more questions on the Senate and on anything else before we talk about the local and regional? Yes.
Can't the NHS Citizen be the Citizen Senate? What I'm trying to get at is it a duplication?
I'm trying to get the right analogy to make it clear why I think it probably can't, because the Citizen Senate is meant to be. Have you got a good analogy? Oh, I thought you might have a good analogy for me to get me out of my analogy trap. But the Senate is meant to be one of the people who are contributing into NHS Citizen in the same way that all of the other organisations that could do are trying to contribute in. My worry with saying that could NHS Citizen be the Citizen Senate is as soon as it becomes something that kind of is an organisation that is an official thing that has to be kind of represented on places, then issues like who's elected, who runs it, and so on become issues with capital I. What we're trying to create is an infrastructure that everyone can use. So we're not creating a new body that has to have a new chief executive and elected representatives and be balanced. It's meant to be open so that what's in there is in there, and every organisation can contribute to it. So it's a slightly different thing, if that makes sense. Yeah.
I've got a mic on, actually. I don't think the existence of the Citizen Senate would preclude anybody else being active in NHS Citizen. There'd be nobody saying if you live in the East of England and you're not in the Citizen Senate, you can't be part of NHS Citizen. It's just it seems like a fairly logical and sensible way, just one means of gathering this stuff, of gathering this information, discovering this information.
Right, I've got my analogy has come to me. NHS Citizen is the internet. The Senate is a website. The website is enabled by the infrastructure that the internet provides, and the internet. Thank you very much. But the internet itself is not something you can see. It's the thing underpinning it that sets the framework within which it operates and which makes sure that everything's connected up.
I don't think NHS Citizen should be that.
I think this is a really good opportunity if we're going to kind of help duplicate it and be a good model around the country, is to make it really good, use all our opportunities to make it the best possible solution as possible, with all the relevant bodies around it, and make it work.
I'm just a member of the Citizen Senate, but when I think about it, to me, it's so very clear in my mind. I've been to probably about 5 meetings now, and it's moved along a long way quite quickly. And it very much seems to me that Health Watch is at a quite large local level. The Citizen Senate is at a regional level, and sort of Justine in running it tends to focus out all the time, on the regional aspect. And then obviously NHS Citizen is at a national level. And, that seems to sort of work. And, I mean, to get anything going, you have to try to keep moving forward very, very quickly. And, I mean, sort of when it came up to the election of chair and vice chair, and turned out to be 2 joint vice chairs, aren't we? Co-chairs. No, but it was done in quite a formal manner, really. Everybody was invited to put their names forward. A proper process was done. So, there's a certain amount of democracy. And also, I believe that all health watchers were invited to put forward a person. So, from working inside and being a journalist, I'm very sceptical of anything like this. It has seemed to be, to me, quite a good experience. And, I think local, regional and national is how I see it.
Cool. This is really complicated. It's further complicated by the fact I can't remember how many there is of anything, because it changes all the time and we all forget, don't we? This is a really simplistic way of describing what the new world looks like. So the 2012 Act created NHS England, which operates at a national level. It's divided into 4 regions. They're massive. The North, Midlands and the East, London and the South. They're not exactly geographies of community. They're geographies of convenience for commissioners, really. Overlaying over these 4 regions, there are 12 clinical senates. Justine says there's 12, there must be. I checked with Mary when I wrote 10. So there are 12 clinical senates. So they're professional senates of clinicians who come together to provide advice to the commissioning system about what we should and shouldn't be doing. So those 12 senates don't actually map to those 4 regions. So they don't share a geography. There's then 27 area teams that do map across the 4 regions. So each region's got its own allocation of area teams. But they also need to work with clinical senates as well. That's all NHS England. There's then 152 local authorities and 152 local health watches and 211 clinical commissioning groups, and they're independent. And we've got a population of 55 million in England, is it? About that's in the UK. So in England, there's about 55 million. We don't talk about Scotland, Wales or Northern Ireland. They don't exist in NHS England world. Don't make it even more complicated. So I think Anthony's analogy of NHS Citizen being the internet, it's kind of the internet that encompasses all of this. And then how do we connect and bind and amplify people's voices throughout it, given the complexity of it? Because it is bloody complicated. Honestly, if you sat down with a blank piece of paper, you wouldn't design it like this, would you? And that's just the commissioning system. So overlaid onto that, you've then got foundation trusts, you've got mental health trusts, you've got other providers, you've got charities, you've got all sorts of other stuff going on as well. So part of this is about how do you, as an individual, get your voice heard by the decision makers here, because it's going to get drowned out by all of this. So how can we then work together through citizen-based networks to pull that together, rather than constantly competing and saying, no, that's our job, no, that's our job. How do we do that better collaboratively together? Does that help? Oh, sorry.
Olivia, is this switched on? Yeah. To answer her question, can you just articulate now, you've explained that, where the Citizen Senate fits?
So the Citizen Senate currently sits as a citizen partner to one of these 12 clinical senates. So in the east of England, they have one clinical senate, and sat alongside that now is the East of England Citizen Senate. So it's an equitable citizen voice into the clinical senate. Is that a fair way of... Okay, it's aspiring to be an equitable citizen voice so that clinicians who are doing their advice and doing what they do very well have a direct route to citizens' perspectives and views and their voice in order to be able to share that conversation. So I think the aspiration on one of the slides would be that each of those clinical senates had a sister citizen senate, so that there was that citizen voice at every level of that system. Does that? Patient voice, citizen voice. Who are patients if they're not citizens? Personally, I have a really big issue with the word patient because I'm not very patient. I'm actually really impatient.
It's a down-putting term.
I think there's also... Sorry, Peter. This is the other mic. No, yeah. I think there's also something about citizens and patients distinction, because sometimes people will be coming to NHS Citizen to comment on issues that they have not personally experienced as a patient, for which, as a citizen, they absolutely have a right, and as a potential future patient, they absolutely have a right to be involved in. And I'm thinking here about hospital reconfiguration as a classic example, which is something that, you may not be going to that hospital, but it's absolutely your right as a citizen to be able to say, I would rather it was in Crowborough than in Hailsham. So it's those sorts of decisions are citizenly decisions, and I think there's a lot of overlap. But I do think it's important to keep the citizen concept alive there.
Actually, the term means patient clinical participation. It doesn't mean clinical observation. If you're going to have a more reciprocal, more mutualistic approach with people, you've got to be working on an even basis about your own health and public health. And the whole notion of a top-down system with an over-exclusive emphasis, in my view, on medication is not the way to do it.
I completely agree. I think there's all sorts of things that are thrown up by that. I mean, you're right, and what we're trying to do here is exactly what you're saying. There's also a much broader cultural thing about, National Sickness Service or National Health Service and all the things that go with that.
I think this is an important conversation because looking into the future, we've got a huge group of people who are going to be around for a long time with dementia, and their families and advocates are going to have an important voice, just as families of people with learning disabilities do now. So we've got to have this citizen rather than patient voice respected and being an articulate, well thought out voice. We may as well get used to it now.
Hi, thanks. Yeah, just an observation, really. It just strikes me from listening to all that the way we're trying to describe the way we're deploying the patient voice is through the strategic commissioning policy side of the NHS that doesn't actually make an awful lot of sense to most NHS citizens, and I just wonder if we could turn it around and try and, I mean, the three words when I go out and engage with my communities and citizens is that people understand commonly is doctors, nurses and hospitals and GPs, and if we can just start to turn the language and the point of access to getting into NHS citizen into those sorts of terms and things that people are aware of and understand. They don't need to know about all that, do they?
That's a really, really good point. And I'm having lots of conversations with providers at the moment because actually people locally connect with the services that they're accessing. And so in a locality, why would the CCG be having a different conversation or trying to talk to the same people twice that the providers are talking to? So how can we join up some of those conversations? And that's when my head starts to hurt. Can I just introduce Victor, who's at the back? You can't speak because you don't have a microphone, but we'll get you a microphone. But we'll let him take his jacket off and listen to the conversation, and then we'll put him on the spot.
All right. Any more questions on this before I start getting you doing all the work again? No. Good. Okay. So what I want you to think about in your tables for the next 45 minutes or so is the local element of this. So, we've heard about, things that are happening here in Cambridge, things that are happening elsewhere, and thinking back to the morning's conversation when you were thinking about how do you want to get an issue in, how do you want to get an issue out, how do you want those issues to be discussed when they're local issues, and how locally do you want responses to happen? Because what we're talking about is something that might be on a very small scale. It might just be a town, it might just be a county. And who are the right people to talk to? How do you want to talk to them? How do you want to handle these issues at local level? Particularly, how do you want to manage conversations that might be about somewhere that's very physical? Do you want to, how would you get an offline meeting together? How would you want support for that? So NHS Citizen is designed to enable you, or will be designed to enable you, to have those conversations at every level, whether it's local, whether it's a local issue, regional issue, national issue. But we need your help to think through how the local element of that might work and how you'd want to see things work at local level. Now, we're lucky in the room to have people who are involved in local campaigns, people who are involved in running local services, people who are involved in the strategic element of those services. So can you just look around your table, and if you're all local campaigners, split yourselves up around the table so that you've got a different mix. And if you're all local authority or NHS staff, move around the table so that on each table we've got a couple of people with different perspectives, and we can do a little model of how a local NHS citizen discussion might work. So I'm going to give you 5 minutes to do the switcheroo, and then we'll come back at 3 o'clock and we'll feed back on how that discussion went.
Fiona's quite rightly pointed out, I said Victor's arrived. I didn't actually say who he was, which is quite rude because I just kind of assume everybody knows that everybody I know. So Lord Victor Adebowale is, in this role here today, a non-exec director of NHS England, and he's been the champion behind this work and a real advocate for making sure we do this as a bottom-up approach to making sure we've got genuine citizen participation. And in his real life, he's chief executive of Turning Point. That's the job that really matters, because actually a lot of this and the championing that Victor's done is built on this, the whole thing around community and how we enable and empower communities. So that's my little introduction to you, Victor. But if we break into work groups, Victor will move around and join in with conversations, and then we'll bring it back.
Okay, so stand up and move around and make sure you're at a mixed table. And we'll any questions ask, but we'll be back at 3 to talk about. Okay. So I want us to spend the last, it won't be more than 43 minutes, talking about, feeding back a bit from the session that we've just had, talking about what local NHS citizen ought to look like. But then also hearing from Victor and from Olivia about their reflections and next steps. So I want us to get started quickly. I'm going to run this not as a traditional this table, then this table, then this table. I want it to I want to turn it into something a bit more conversational. So I'm going to pick on a table at random. In fact, it's going to be that table, so you've got a moment to think about it. Just to say one thing that came up in their discussion, and then I want to hear another table who said something related. So one thing that came up from your discussion on what local NHS citizen ought to look like. Don't be shy.
I think what we felt was that local doesn't fit one size. It's different everywhere. It has been designed for local areas and for their own local geography. So it's how we overcame that and how we would connect with that.
Did anyone come up with a suggestion as to how we can overcome that different sort of geography and the fact you've got lots of different organisations at different scales? Did it come up in anyone else's table?
Oh, I'm sorry. I think we've sort of talked about everything, really, but we just wondered how NHS Citizen, it's the same other thing I've mentioned before, how it will reach areas that are hard to reach, and how we can encourage those people to get involved.
Okay. Did anyone else... You see, I'm deliberately trying not to answer the question because I'm not the focus here, you are. Did anyone else think about how to access hard-to-reach people and how to find groups in the area or groups in local areas who weren't being involved?
Oh. I think one suggestion was made that in very much rural areas you could contact people like the WI, who are one of the main sources for the women folk of get together and not just making cakes. And the other thing is, of course, in the market towns, there's usually a centre whereby you can advertise for nothing and leave information around.
Did anyone else talk about getting the word out and spreading the message in rural areas or in villages? In which case, I'm going to pick on this table, who hasn't said anything yet, to say one thing about what they said.
We just wrote down on a little post-it note, when is local, who decides? And when, if local health authorities form regional networks, will the need for clinical senate decline or change?
Okay. Sorry, go on. Clive.
Rather than local authorities.
Right, okay. Justine? Do keep any notes that you took so that we can pick up your thoughts if they don't come out in the session.
So I'm slightly reluctant to say it, but it does all come back to the fact that something like a citizen senate could solve a lot of these things. Am I not right in saying? Yeah.
Okay.
It's like you talked about it, not me.
Remind me and then I'll join in.
Okay, so connecting citizens with professionals and commissioners.
Thank you. One of the things that we do, which I didn't explain at all earlier, is that the citizens who come to Citizen Senate all have their experiences, and that's why they come. And as well as sitting on the Citizen Senate and debating the issues, I also filter them into various work streams and projects, which are service improvement projects, so that they can work alongside healthcare professionals in using their experience to make a difference. And so we felt that this could be an important part of the sort of, whether that's gather or discovery, I don't know, so that the discussions weren't just happening and then nothing was coming out of them, but actually be an output of the discussions.
The other thing that we did talk about, because clearly our group has all gone home actually, was this thing about the local stuff can be really difficult for somebody. So if you have got, we talked this morning a bit about fear of how you would be treated in a service if you raise an issue or raise a flag. So and the example we used was transgender services and transgender people accessing GP services. If your GP is transphobic, how do you say that locally without fear of reprisal from your neighbours and other people who live in your community because your trans status is so stigmatised? Actually, by just making yourself visible locally, you put yourself at risk. So is there something in the digital elements of this that allows people to raise issues in a way their personal identity, i.e. where they live and their immediate local area, isn't put at risk, so that you can engage in a conversation, but you can do that in a way that doesn't make you feel that you've been stigmatised?
Just to add to that, that is already happening on Twitter, which I'm sure you're aware. But there's, for instance, a group of young people with HIV who talk on Twitter but don't reveal their identities. So.
You can also talk to your local health watch. We keep the data, the information we're given is completely anonymous. We don't record your name, address. All we do is record the first 3 letters of your postcode, so we know roughly where you live. Not close enough to identify you. And we would never disclose it.
I think that points up one of the things that came up elsewhere in the discussion that I heard about, which is the connection between Health Watch and NHS Citizen. And I think that in the same way that the Citizen Senate is a good vehicle for some things and Health Watch is the right vehicle for some things, the purpose of the local is to find ways to make the conversation better and to join up what's happening. So it may well be that the local Health Watch are the people who are animating a lot of the conversation at local level about the issues the NHS Citizen is giving people opportunities to raise, or vice versa, that things that local Health Watch think are a problem, they can put into the NHS Citizen system to say, well, actually, here are the other people in your area who are thinking about this. Here are the other ways in which people are having conversations about it elsewhere. So it gives visibility across the different conversations that are going on, but also some tools that allow people to create local conversations, sometimes very local parish hall type conversations, and sometimes small audience digital conversations. Because I think one of the things that's interesting for me about local is that localities are things that happen in a single place and bring together all sorts of different people. But you can sometimes have a conversation that is just as small as a small village, because if you're talking about an unusual condition or something like that, that digital allows to happen as if it were in a single place, but across a very wide audience. So I think NHS Citizen needs to manage small audiences that have very, very similar needs as well as it does small places. So anyway, I don't want to do all the talking, though. Indeed, I don't want to do any of the talking, ideally. Does anyone else want to volunteer an issue that they raised that we haven't picked up yet in the kind of the localness of this?
I was out of the room for a few moments, so you might have picked this up already. I don't feel that there's a great deal of clarity come out of this afternoon's thinking about where Health Watch, where Citizen Senate and so on overlap, support each other, enhance each other. There seems to be more confusion at this stage, and I think that may well be a healthy confusion, because I think that discussion needs to go on and development needs to occur. But at the moment, I'm not sure what local means, because local, at a local Health Watch level, could mean something that's happening in the Cambridgeshire area, for example. Citizen Senate is described as something that is actually regional, which is above that level. So does local have a different meaning in those two environments? What does that... And people, I think, are not clear at all about that.
Okay, I think the thing to say from the NHS Citizen perspective, I'll come to... Olivia, you're leaning forward in a kind of... Can I have a word? No? Fine, okay. All right, so let me talk about NHS Citizen first. I think the really important thing to remember about NHS Citizen is that its currency, its kind of basic unit, is the issue that you've raised. So there won't be an NHS Citizen Cambridgeshire. There'll be stuff happening on NHS Citizen that is to do with Cambridgeshire, but sometimes it'll be raised by someone in Cambridgeshire and it'll be a national issue. So Healthwatch is very much more localised. Healthwatch England is national, of course, but Healthwatch as an institution is localised, and the Citizen Senate is regional. Now, the Citizen Senate is designed to sit alongside the Clinical Senate and to work in that kind of bringing voices together kind of way. Healthwatch is much more of a vehicle for people to raise issues and concerns as patients. So for me, there's a distinction, which is that Healthwatch is there for the local and the patient and the concerns being raised. NHS Citizen is a tool that it can use, but also is a broader national window that allows you to raise issues that don't necessarily relate to your area.
As health watchers are beginning to network together at a regional level, I remain confused as to how that's supposed to fit into the whole thing, because some of what we've been talking about Citizen Senates doing surely will become part of what networks of local health watchers do.
I think it's important to draw the distinction between NHS Citizen and the Citizen Senate. So the Citizen Senate, I'll pass over to Justine in a moment, is something that's separate from, but with the same ambition as NHS Citizen, to try to bring together people's voices and to increase public voice. Now, it may be, as we were saying, that a regional network of health watches does the same or a very similar job. So, I think the question is not, like you say, it's a helpful confusion, because what we're trying to do is collectively work out what's the best way of managing this kind of public and patient voice. So I don't know, Justine, if you wanted to kind of come in on how you saw the locus of the Senate, the Citizen Senate.
Well, as Mike knows, because Mike is a member of the Citizen Senate, actually when we devised it, there certainly was no regional coming together of Healthwatch, in fact, quite the opposite. So I'm quite surprised to hear that you think that there might be, actually. That's good if they are, that's terrific. But obviously we're aligned to the Strategic Clinical Network and the Clinical Senate and can feed people into the work streams going on there.
At a workshop last summer about NHS Citizen, I remember there being quite a lot of discussion that really echoed that worry. And more generally as well, there are so many bodies already, there are so many patient groups, there are so many stakeholder groups, and there's Healthwatch, which is also already gathering a lot of, I think, data as well, isn't it, as well as information. And actually, one of the things that we said was, let Healthwatch be Healthwatch. I don't think NHS Citizen, and I certainly don't think the Citizen Senate, oh God, are trying to do the jobs that other bodies are doing. In particular, they're not trying to duplicate what Healthwatch is doing, and in actual fact trying really, really hard not to. But it's a different kind of feel, it's a different kind of body, I think. Very, very patient-led.
Okay, so we've got one comment here, and I'll come back to you, Clive.
I think I see the issue between Healthwatch and Citizen Senate. Healthwatch is, for a start, much broader. It's concerned with social care as well as healthcare. So it's actually broader than you guys at Citizen. But it's quite local. However, we can use the Citizen Senate as a way of accessing the people who can influence commissioning, especially where it's specialist commissioning within NHS England. And everyone says the clinicians doing the commissioning sit in the CCGs. I don't know about most diseases, but 80% of the cancer budget is in specialist commissioning in NHS England, so it's a lie.
I think duplication isn't the word that was in my mind. What was in my mind is about how each of the different bodies, and we've got 3 bodies altogether in the way, add value to and add emphasis to the patient public voice. And that's what's my concern. It's about how that voice is emphasised. I'm sure we can get around the duplication, but how do we get an effect from that voice?
And as I just wanted to add something that I touched on, and it's not really very clearly thought through at the moment, but it's really about something that I think can only happen at local level, but the NHS Citizen won't be able to do locally, and that's around the relationship stuff. So the co-production and the Health Watch, voluntary sector, CCGs, people being round the table to work together, I don't think NHS Citizen will be able to replace that. It will be able to add to it by bringing in different views and being able to perhaps look at views in the sort of gather and discovery way in a different way and add value to that. So I think another way of looking at it is that only those relationships, local relationships, can make change happen, and NHS Citizen can help add to that, but certainly won't replace it. So I just think that might be another way to just think about it in a different way.
I think that's very helpful. I think the point about the local relationships is really correct, in that NHS Citizen is not meant to be a thing that has like a local meeting or anything like that. It's a set of issues. I want to not give more than about 5 minutes to this so that Victor and Olivia have time to talk. Anything else that hasn't come up that people talked about on their tables, or that they think is a local, regional issue? Yes, Clive.
I think the Citizen Senate is excellent, but I think we need to have 12 of them alongside the clinical senates, which can then work very closely with the NHS Citizen. And I would like to see some professionals with us as well.
That's true. In fact, are we not going to the BMA conference, Olivia? Are we? I'm sorry. I know, it's almost Friday as well. So, yes, one voice over here.
Hi, I just had an idea on our table earlier. I just wondered if we could be a little bit more proactive about the way we push NHS Citizen, and maybe go for an idea of what it takes to be a good NHS citizen, and actually start to espouse some sort of good behaviours around how to access the NHS appropriately and responsibly, for example. Why it's so important that you don't repeatedly cancel or DNA your outpatient appointment or GP attendance, those sorts of things. And that gets the NHS into that sort of community leadership space that perhaps local government's withdrawing from, and might be a good opportunity.
I think it's really, I mean, it's too long a question to talk about now, but I think opening up the question of whether there are responsibilities that come with the rights of citizenship is true across the entirety of politics. But yeah, it's a really good point, which we'll record and think further on. In fact, it might even be is there a kind of, not a code of conduct, nothing so strong as that, but is there a this is what it is to be a citizen sort of conversation to happen? Yeah.
Oh, and a voice over
Sorry.
So one here and one there.
Okay, so yeah.
Given that we've got this far now, and we've explained what the Citizen Senate does in relation to NHS Citizen, how about, can I propose that we try and experiment and use NHS Citizen to link with our other regional Citizen Senates? I'm thinking carefully so I don't get the words mixed up. Is that possible? I'm thinking the practical...
It's certainly possible to have a conversation about it, but not possible to decide on it now. But certainly, yeah, let's
sure.
talk about that.
And is that something, Justin, we could explore?
I think we've always offered that if anybody wanted to do a similar thing, and in fact we are trying to support the West Midlands who are trying to do a similar thing, that we'd be available. But obviously you can't tell people that that's what they have to do, which has always been the problem. And why should they if they want to do something different? So, but we know that it's starting to work for us, and if we can build on that, that'd be great.
So just something on a very personal level. A personal worry that I've got is the eroding of a lot of groups' voices. And I know a lot of advocacy is not commissioned anymore. So I think the Citizen Senate model could keep alive a huge amount of that voice, which is really in danger of being lost for very vulnerable groups. So if there's, it's just another reason for replicating it.
It's a good point. Thank you. Yeah, if there aren't, no, that's a leading question. Are there any more comments? No? Yes? No? Yes? No? Fine. Okay. So I'm going to ask first Victor and then Olivia to sum up. I think we've had a couple of good sessions of conversation, but this is just, as I say, another stage on the journey. You can go and see yourselves in full Technicolor online on the nhscitizen.org.uk website, at least when the archives are up in a few days' time. And also we'll be writing a very quick blog about that, what I do on the train home, and Clive will be doing a full report. So...
No, sorry.
No, okay. You're not talking about BMA again, are you? No, it'll make her upset. So I think the next stage is a meeting in Bristol, where we're actually going to be putting some concrete stuff around what NHS Citizen might look like, at least online. So it's a 2-day event in Bristol, and like we say at all of these things, if you want to stay involved, there are plenty of ways that you can come to events, and there is a travel budget for volunteers and patients who are keen to come to events and take part in NHS Citizen. Next event is in Bristol, but I'm sure we will be back in the east of England at some point before the project reaches its final prototype stage, which is meant to be in April next year. So I'm going to hand over to Victor.
Okay, so it's been an interesting afternoon, first getting here and then... So I need to say a couple of things. First is that, as Olivia pointed out, I have a day job, which is Turning Point, and they just won't leave me alone this afternoon. So I've managed to get to 3 tables, but I've missed 2, for which I apologise. You guys actually were undisturbed, so you probably produced something quite creative, whereas everyone else is just a pet. So I got, there are some observations, and these are just observations, snippets really, of things that I heard, and are things that allow me to reflect, I guess. I was quite intrigued by people. There's several ways in which NHS citizen senates, I don't have... the Senate thing isn't everywhere. It's here. So you need to make it work. In other places, it doesn't exist. I want NHS citizens to exist everywhere, alongside whatever there is. So I asked the question, is it in competition with the NHS citizen? Because I'm from Yorkshire, I don't do diplomacy. So it's straight away, no, it's not. It could work together. It could work. It could be the one place that people go. For instance, most people do not speak NHS. They just don't. And if they want to engage, if they want to complain, if they want to attach, they need somewhere to go that's simple, that doesn't speak NHS, but will take them seriously. And I want NHS citizens to be that place. What happens after that is up to you, basically. I think that's one of the things that NHS is lacking. But I was struck by a number of themes. One is the connection between the individual experience of services and the inflexibility, or rather lack of it, of services. And that struck me when I was listening to Vicky, actually. It was you. And it just struck me that, you keep asking the question, well, why? Commissioning should be the means by which you understand the individual and or the community, such that you can create a platform for procurement. If it is cheaper to provide a service for an individual than to say we don't do that, the computer says no, that's not commissioning. That's wasting my money. So there's a question which is quite immediate that NHS citizens need to be asking, which is why? Why isn't it flexible? What is that about? And the response can't be because we commissioned it that way. I think you have every reason to be, frankly, frustrated with that response. I was just intrigued as a practical thing. What just NHS citizens going to do practically? It must make a difference at that level. It must do. Otherwise, what's the point, right? So I got that impression that there's something about the flexibility and how we encourage or engender that within the place. I came to this table. Paul, John, Helen, Trevor, and I was really struck. The thing that I walked away from was something that I think it was Stella said, which, again, was the simplest thing, but seems to me the blinding glimpse of the obvious. The NHS is, you could argue, only exists because there are ill people, or people who are healthy that worry about being ill, and people that are ill that want to be healthy. Without them, there is no NHS, right? But it's just dawned on me that sometimes the conversations that we have in NHS, the impression that you'd get is that it's the other way around. It just seems odd to me. And I personally see no value in not assuming that actually at the centre of the NHS is you. So I was just struck by the fact that Trevor handed a piece of paper with a whole load of stuff about the Senate, and Stella, if you don't mind me saying, started reading it and lost the will to live after about page 3. And I think for me, NHS Citizens isn't about documents, it's about relationships and conversations that actually engender a sense of, well, why, but also there's a rationale, there's a kind of purpose to this, which is, if it doesn't make a difference to the consumer, the customer, the people paying for it, which, by the way, are you, what's the point? And it just struck me in that exchange that NHS Citizens need to refocus the NHS, in a sense, quite powerfully on that. I think when I came to this table, one of the things that's really practical about geographies and almost the difference between what is local and what is regional and what is national, and how do you make those connections real. And I put forward an idea, you know, and it's not saying you should do this, but I got this sense that partly one of the things about NHS Citizens, which is a worry to me, is that people have experienced engagement and this kind of thing as actually quite negative. So people come to meetings, they get surveyed, they have discussions, and frankly, bugger all changes. I mean, I'm being exaggerating to prove a point. What NHS Citizens need to do, and one of the things that I think is really valuable around NHS Citizens, oddly enough, is the noise about the NHS. You know, it's running out of money, there are these kinds of issues around services. I think that's fuel. Actually, it's fuel for you to do something locally. You know, these services happen locally. You know, so you can use that to establish what's happening in your town and your village, ask questions. There's always one person that wants to do the electronic stuff. What I'm saying is it is solvable by you, but starting local is defined by you. It's not defined by NHS Citizens. Yeah. And finally, I just wanted to say something. I've been thinking a lot about what engagement actually is. How do you know when you've done it? And this has been broadcast, and I don't know whether there's going to be people out there that are going to shoot me for saying this, but there are four things that matter. I'm going to throw this out. You tell me that I'm talking nonsense, but there are four things that are the requirements for engagement. And if these four things don't happen, in my view, you haven't been engaged. All right? The first is, any engagement must involve a transfer of power. If there's no transfer of power, what's the point? And I don't mean all power, but some power, something. You must feel that you have, as a result of the engagement, there's been some transfer of power, which is one of the reasons of NHS Citizens. NHS England wants to give some power away. Right? There has to be some transfer of power. The second thing is there must be a shared understanding of outcomes. If I talk to you and I tell you what the outcome of that conversation is going to be, and I decide the outcome for me, and I never ask you, and we never talk about it, and you never agree, that's not an outcome. That's my outcome, job done, see you. So there must be an outcome for both people that's understood and agreed. There must be an outcome for the patient that's understood and agreed, and the citizen, otherwise you've not been engaged. There must be a design that you can understand for the service. In other words, the outcome of all this must be services that you can say, this design works for me because, and when I say that, I mean literally the conversation that Vicky was having about her son. Sorry, Vicky, but, to talk about you, but the conversation that you were having about your particular situation, it strikes me that, that service is failing. And it's failing because you can't say, that service does this, this and this for me and my son, and that's why it works. And you can explain it to a neighbour in English. Do you know? Yeah? Now, that's, if the design isn't explainable, then it's not usable. If it's not usable, then it's wasting my money. It's very simple. I mean, and the fourth thing is that you have to listening. One of the things that happened at this table was that at one point several conversations broke out for reasons I won't go into. I'm not having a go at anybody, but you two started having a chat. You started having a chat. You having a. It was his fault. Yeah, I'm not. Believe me, I'm not being critical. I'm simply saying that if I have a conversation with you, Fiona, and I say, you've been listened to, Fiona. I've really listened to you. Thank you. But you say, so there you go. There you go, because who decides whether you've been listened to? You do. And if you haven't been engaged, now those for me are the four rules. I'm throwing that out. You might disagree, but I kind of this afternoon, just listening to you guys, I just thought, you know what, there's something that could be really powerful here if those rules apply, and if we can generate a mirror. What I want NHS citizens to be is to be a mirror that's held up to NHS England and says, well, this is what you said you were going to do. This is how you said you were going to do it. This is what we're getting. If it's the same, great. If it ain't, come on, we're paying for it. Enough said. Yeah, enough said. Thank you very much.
Thanks, Victor. That's really powerful. So I'm not going to talk for ages. I'm going to try and... No. I'm just going to try and wrap up and do a little bit about what next. But I just want to say a little bit about what I've got from being here today. Because we're doing this, we're going around, we've been to Sunderland and Liverpool. Is this number 6? Okay, I can't remember the other places we've been then. Exeter, that's a really long way from Yorkshire. It's a really long way on the train. And it's kind of, we have to question in doing this, why are we doing it? Why are we webcasting it? Why are we doing this kind of roadshow around the country? And actually, today's exemplified that, because the mix of people in the room, from people who've never participated in something like this, to people who are deeply cynical. I love cynical people. To young people, older people, actually, there's a whole load of stuff that's come out of today that will further develop and refine what we need to do. And we need to constantly question what we're doing in order that it's useful. So actually realising that we have to explain that to some degree, but maybe NHS Citizen is the front door to that. Do you really need to get into the complexity of all of this rubbish that doesn't actually make very much sense? Or do you need a doorway to go through that helps you to find the right place to have your issue dealt with? And I'm not sure we're getting that. The whole Health Watch question, let Health Watch be Health Watch. Okay, so we can constantly have this conversation, is this local health watch? Every local health watch I talk to is really strapped for its own, the pressures on local health watch in terms of doing a great job locally for their communities are huge. So maybe if we stopped doing the isn't this health watch, isn't this duplicating, and we all crack on and do what we're there to try and do, maybe we'll start to have impact, as opposed to doing the protecting our own perceived power places, because I think that's a lot of what we're doing. And that's probably quite contentious, and I'll probably get shouted at by quite a few Health Watch people for that. But there isn't one answer. We talked about this locally, about the geographies. There isn't one answer that works for everybody, and we're not trying to design perfection. We're trying to get to a place where people have a voice that has impact and influence, and the boards of NHS England can sit up and recognise that it is there to serve the people of England. So that's my little rant. I'm very reminded that this is about a community development approach to doing something by the words that Peter, who's left us, talks about, in terms of this is a community workers approach to building a proper voice. And it needs to be that. It doesn't need to be something that's a professional voice. It doesn't need to be something that the system's designed. It needs to be designed by people like you. So it can work in schools, it can work wherever, but it's got to be visible. It's got to be led by people who want it. Making sure we explain ourselves in simplicity. we need to keep calling ourselves out on using language and assuming that people understand structures and assuming that people understand ridiculous things, that why on earth would you, if you're accessing your GP service and you're not that happy, why would you need to know stuff? It's stupid and we overcomplicate it. What makes an NHS citizen, and your point about the whole thing about our own behaviours, people don't turn up at GP appointments for very many reasons, and part of that is about the way the appointment systems work and the way the practices are organised. So if we consistently write to people in a letter that arrives in their letterbox and they're visually impaired and they can't read it, they don't turn up at their appointment because they didn't know they had one. There's some work that's been done by a guy called Harry Longman, I think he's based in Leicester, around patient access, and if you Google it, you'll find it. It's brilliant. We could probably link to it on the microsite somehow, about how you remodel and rethink the flow through a GP practice to reduce your DNAs to almost zero because you're actually connecting with people. And we're not using the learning. As Fiona said earlier, something brilliant is happening everywhere, but we don't necessarily learn what's going on in different places, and then we end up competing and reinventing the wheel. And a lot of that is about power. And I think we really do now need to move to action. So we need to move. I think we've got a model that we need to be better at explaining and visualising for people, so something very strong about visual explanations of things. But we need to test it out on some real issues. And we've got the opportunity to do that. Here's one we prepared earlier. So the NHS England AGM in September that Fiona was at last year, immortalised on the webcast forever. 18th of September. We're going to take the whole day and use it as an attempt to test out what an assembly process might look like. So we'll put a call out to invite people to come along to that, and we'll make sure it gets out around your networks. But alongside the call for people to come will be a call for issues, a call for things of, actually, let's talk about this. This is the issue I want to gather and convene around. And we need to get that underway in the next few weeks so that we've got a real issue that we can bring people like you together with clinicians and commissioners and decision makers and the boards of NHS England, because I'm really interested in that dynamic, because we can bring patient engagement and patient involvement people together with people who use services, and they can have a great conversation, and that happens quite a lot. But actually, I'd like the finance director and I'd like the lead commissioner and the people who make the decisions about those services to be having those conversations with the people who use those services. And that's what I like to think we might be able to try and do for the AGM in September. And I think that's all I wanted to say. Fiona wants to say something, though.
Sorry, I'm just sitting here really kind of twitchy. I'm not sure why, really. I think it's been a great day. I think the thing to take away is that what we're suggesting nationally and locally is a long way from perfect. There's all sorts of questions to be asked about how it fits in with that, and is it treading on somebody else's toes, and exactly how it will work. But actually, the NHS board has taken a bit of a flyer on this. The idea came from the NHS board, didn't it? We aren't accountable enough. We ought to be more accountable. How do we enable patients to hold us to account? So they've opened the door there. And I think we should be just bloody running in, really, with a thing that isn't perfect yet. You know, if we wait till it's perfect, if we wait to get it exactly right, we'll have missed the boat. We'll have missed this beautiful opportunity. And I think we should just not worry about it too much and fix it as we go along, you know. But to make a difference, we've got to be able to go to the board fearlessly with issues like the one Vicky raised earlier, which is, you know, it's an issue that's as plain as the nose on your face. It's one of those issues, like lots of others, we should just be quizzing the board about. Why is budgeting so bloody complex that you can't get the care you need, even though it would be cheaper than what's currently in place? This kind of thing. We shouldn't be waiting till everybody understands that, you know. We should just be getting the banners and running in.
So we're having banners in September. Okay, does anybody want to make any final remarks before we finish for today? I don't want to talk for 2 minutes and 30 seconds more, please, really? Do I have to? They don't want me to talk for that long. Okay. There's Birmingham in October, and it's the second. If you go to the website, they're listed there.
Yeah, nhscitizen.org.uk, and have a look there. I think it's the 21st of October, but have a look at the website.
Something like that. So we're in Birmingham in July. We're in Bristol in July for 2 days, or the Wednesday evening, the Thursday and the Friday. We're doing a session in a prison on the Thursday morning. That's going to be interesting. And then we've got the AGM in September, where we'll test an assembly type process. And then Birmingham in October, and some other places along the way through to next year.
London in January.
Okay. Can I thank you all ever so much? I think you're probably the most diverse group in terms of where you come from. So we've had local government, we've had social care, we've had people who've never been involved, we've had younger people, thank you very much, and very much more mature people. And you've all brought a very different lens, and that's really valuable. So thank you ever so much for your time and your cynicism and your challenge. Because I think you're helping to build this into something that will be really, really powerful. I wish you a very safe journey home. Thank you very much for your time.
Okay. Right, well, can I introduce Anne Robinson, are you a resident of Cambridge, Anne?
I am a resident at Cambridge, yes.
Right. I'm Clive Mitchell from Involve. Anne's been here at the NHS Citizen Workshop in Cambridge today, and we thought it'd be helpful to sort of share Anne's experience of being here today. So, if I could ask you, Anne, just to say a little bit about sort of what motivated you to come to the event today, and tell us a little bit about your sort of experience.
Okay, I was actually on Twitter when I found out about NHS Citizen, and I read a bit about you online. The circumstances that I'm in at the moment is that I represent a group of patients with personality disorders in Cambridge who were told in one-to-one meetings that we were being discharged back to our GPs with no support whatsoever. The community 2-day a week that we had is called LifeWorks. And we tried to get them to listen, but they wouldn't, so we ended up doing a sit-in in the clinic. And today, this week is our 15th week. We've tried and get the CPFT and the CCG to be held accountable. But it just seems to be that they don't seem to be accountable to anybody. Nobody. Zero, zilch and nada. In that time, we've had an EDM tabled, and I'm going to meet the shadow.
What's an EDM?
Early day motion. Our MP has put an early day motion in at Parliament, and there's a group of us going down to Parliament on Tuesday to see the Shadow Ministers for Health. And we've got an online e-petition and all that going. But the thing I like about this, the reason that I've come here, is because I found my voice for mental health. And I fought for everybody else who goes to LifeWorks. There's about 200 of us go to LifeWorks and aren't able to speak up for themselves. I certainly don't want to see any other mental health patients going through what we went through. And I'm now looking to be a voice for others, other mental health patients, to make sure that trusts, health authorities and CCGs do not treat patients with mental health issues the way they treated us, because just because we have a mental health issue does not mean we do not have a voice.
Great, thank you, and that was really powerful. So, just one more question, if I may. So, what have you taken away from the event today? Sort of, what's your key reflection, if there is one reflection, about how NHS Citizen might support you to have that voice more strongly?
My view about it is that you're not up and working now, which is a shame. Because if you had been up working now, I'd have red flagged, and it would have gone straight up, hopefully, to NHS England, who we have tried to get hold of. Because when Lucretia Berger came to visit us, and she's the Shadow Minister for Public Health, and we asked about who we can hold them accountable to, she said Health Watch and NHS England. So I'd have red flagged as soon as we started the sit-in and waited for the information to come back and try and... because apparently they're the only people that the authorities would answer to. I don't know whether that's true or not, but I'm about to find out.
Okay, thank you very much, Anne. Thanks for taking the time to share that experience with us, and appreciate it. And thanks for being with us here today.
You're welcome.
Cheers. Bye-bye.
Is that okay?
That was absolutely fine.